Saudi Arabia, and then joined the Canadian system with the Canadian Clinical Fellowship in Inflammatory Bowel Disease, and also he has a fellowship in clinical epidemiology and biostatistics. And Dr. Fahad, I think he's working at Fahad Hospital at Riyadh. So the floor is yours.
So, assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the nice introduction, and thank you for the organizing and scientific committee for inviting me to talk about the nutrition in IBD. Here is my disclosures. So my objectives for this talk to highlight the role of the nutrition in IBD management, identify the common dietary mistakes in IBD, rely on the clinical trial evidence and adjust the population studies, and we will end up by deliver holistic care without unnecessary restriction. So is the diet matter? So the importance of this topic is that the diet can modify the inflammations and gut. Also, as you know, the drug is effective but not complete. So we need some energetic effect that can help to maximize the therapy by the diet. And also the diet has a role in the therapy and prevention. So let us to start with the dietary beliefs and behavior in IBD patients. So this is a prospective questionnaire study. They include around 82 adult patients, 48 Crohn's disease, and 34 is UC patients. As you can see, the result here is that 85% of the patient, they think that diet trigger relapse. 81% they impose the food restrictions in their diets. 90% of the patient, they avoid food during a relapse. And around 87% they avoid food even during the remissions. And 65% of the patient, they skip meals during a relapse. And the most interesting thing is that only 30% of the patient, they receive professional dietary advice from the dietitian. So now we're going to start with the mistake one, thinking the nutrition only works in children. As we know that there is a clear guideline and the statement about the role of the exclusive enteral nutrition in pedia. So there is the statement said exclusive enteral nutrition is recommended as a first-line therapy to induce remission in children with active luminal Crohn's disease. But what about in the adult? So this is a systematic review, a meta-analysis. They include more than 1,000 patients. They compare the exclusive enteral nutrition versus steroid in active Crohn's disease. So in children, when they do the intention to treat analysis, as you can see, they compare the exclusive enteral nutrition versus the steroid. The achievement is 83% remission in pedia versus the 61, and there was no difference between steroid and exclusive enteral nutrition. In adult, with the intention to treat analysis, as you can see here, 45% with exclusive enteral nutrition versus the 73, and this was statistically significant. That means steroid is superior to the exclusive enteral nutrition in adult. But when we do their protocol, and this is very important, that the compliance to the diet is so important. So as you can see here, the remission rate was increased in the pediatric 89% versus the 61, and this is statistically significant. In adult, there is increase, but still the steroid is superior. So in the adult, it doesn't mean that diet is not working, but the steroid is superior. Currently or recently, there is an recent consensus on the dietary management, and they mention clearly that exclusive enteral nutrition is effective for the induction of the clinical and endoscopic remission in children and adults with the mild to moderate Crohn's disease patients. So what about the restricting exclusive enteral nutrition only to the mild small bowel disease? Does the exclusive enteral nutrition working in the complicated Crohn's disease? Let us see the prospective observational study. They include around 41 patients with the Crohn's disease complications, 12 weeks of exclusive enteral nutrition through the nasogastric tube. 80% of the patients, they achieve full clinical remission. Regarding the mucosal healing, as you can see, 47% they achieve the complete mucosal healing with the exclusive enteral nutrition. Regarding the intracutaneous fistula, is around 75 of the patients with fistula achieve the complete closure. And for the abscess resolutions is around 76. So there is a signal that exclusive enteral nutrition may work even for the complicated Crohn's disease, not only the mild inflammatory small bowel disease. What about the believing nutrition only improve the symptoms, not the inflammatory marker or the mucosal healing? This is a prospective observational study. They include around 66 of the patients, children with Crohn's disease, and they give 8 weeks of the exclusive enteral nutrition. They measure the fecal calprotectin at day 33 and 54, and after that, they reintroduction of the diet, and they calculate the fecal calprotectin at day 7 and 52 and 72. As we can see here in the left side of the box plot chart, that the baseline of the fecal calprotectin before start the exclusive enteral nutrition is around 1,400. After that, it's decreased up to 800, then up to the 400. After the reintroduction of the diet, there is a rapid relapse of the fecal calprotectin and increase up to the 900 till reach to the near to the baseline 1,000. Here is the same study that what about the cutoff level of the fecal calprotectin showed that patients with very low fecal calprotectin less than 100 at the end of the exclusive enteral nutrition tend to stay in remission longer, and this is statistically significant, while the cutoff of the 250 and 500 did not predict a relapse. What about the mucosal healing and diet? This is another randomized controlled trial including 19 patients with new-onset Crohn's disease. 13 receive exclusive enteral nutrition and 6 receive steroid over the 8 weeks. They found that exclusive enteral nutrition achieved the mucosal healing in 89% versus 17% in corticosteroid, and this is statistically significant. What about the over-restricting diet due to the over-restricting diet due to the fear from the additives? We know that the food additives like the carrageenan and the emulsifiers linked to the IBD in the animal studies. This is analysis of the 61 exclusive enteral nutritional formula, and they found around 100% starch and 22 carrageenan, and the carboxymethyl 13% and polysorbate 5%. So as you can see here from this study that remission rate and it change regardless of the additives. So these exclusive enteral nutrition with or without additives, there is no change in the remission rate. But there is a recent landmark study called the ADAPT trial. It is a double-blind resupplementation RCT. This study was include 154 Crohn's disease, mildly active Crohn's disease, and fecal calprotectin more than 150. They randomized to 2 groups, low emulsifier diet and the emulsifier containing diet. The patient number is 77 in each group. The primary endpoint was that 8 weeks CDI remission, fecal calprotectin, gut microbiota, blood and urine, and optional sigmoidoscopy, and also the long-term endpoint was the CDI remission, fecal calprotectin, gut microbiota, and blood and urine. This trial, it's a novel approach because they use the resupplementation, and this can help to decrease the risk of the bias and also the limitation of the trial. So what are the findings of this study? So the CDI response in the low emulsifier, there was around 49 comparing to the 30% in the control group, and this is statistically significant. The CDI remission was twice more in the low emulsifier diet compared to the control group, and also the fecal calprotectin decreased more than 50% of the patient, 3 times more in the low emulsifier diet. So this is first trial that showing emulsifier restriction effectively treat the active Crohn's disease patients. What about the using the epidemiological link as the treatment evidence? We know that the evidence from the population studies and the epidemiological studies does not automatically translate to the effective treatment. So sometimes we need a strong study like the RCT to approve the principle. So here there is a summarized table that can compare between the epidemiology versus the RCT findings in the IBD nutrition. So the fibers that showed in epidemiological study, it's a protective role, but in the RCT and clinical trial, no significant benefit. Even that exclusive enteral nutrition works with almost there is no fiber. Omega-3, anti-inflammatory and protective in mice, but there was no consistent benefit in Crohn's or UC patients and UC patients. What about the red meat? We saw that some epidemiological and animal study that this red meat is linked to the relapse, but in the phases trial that assess the red and processed meat in Crohn's disease patients. So this is a randomized control trial, including around 213 patients with a Crohn's disease in remission. They randomized to high meat group and low meat group, and they follow up them for around 49 weeks. So as you can see that the asymptomatic relapse between the low and high group, there was no difference, and the time of the relapse is almost same. What about the missing malnutrition? So as you know, the diagnosis of the malnutrition for the IBD patient is so important, and the criteria for diagnosis either one phenotypic plus one etiological criteria that include the weight loss, low body mass index, or muscle loss. This is the phenotypic, and the etiological criteria for reduce the absorption or reduce the food intake, or there is a sign of the inflammation and the disease burden. You know that the prevalence of malnutrition in IBD is around 70%. They have malnutrition, and it's more common in Crohn's disease comparing to the ulcerative colitis. Malnutrition, it can be undernutrition or patient with sarcopenic obesity. So the malnutrition can lead to increased hospital length of the stay, higher mortality and infection risk, more perioperative complications, reduce the response to the medical therapy, greater risk of non-elective surgery, and in children, up to 40% they have growth failure. What about the misinterpretation of micronutrient level during the inflammation? This is a very important point, that inflammation can distort the vitamins and trace element test results. So the deficiency may be over or underestimated. So the best way to assess the trace element during the quiescent disease, or if you have the blood cell level when possible. So as you can see here from the chart, that the percentage change in the micronutrient concentration during the disease activity. And this is very important point, that may will give vitamin based on the deficiency, and the patient will be like over doses. What about the common deficiencies in IBD patients? Iron deficiency reach up to the 90% of the patients, vitamin D up to 1/3 of the patients, and B12, it's a common, especially in the ileal resection. And this can worsen the quality of life, fatigue, bone health, and disease outcome. So as you know, the treatments, sometimes the oral iron inadequate in active disease, sometimes we need to give the IV, and it's preferred. Vitamin D monitor and replace routinely. The vitamin B12, sometimes the patient will need it for lifelong supplementation for those that the ileum is affected or resected. Always consider the age, disease, medication like the methotrexate, and some patients need higher dose than guidelines. Mistake number 9 is the ignoring the exercise as a part of the nutrition management. So exercise is safe and visible for the IBD patients. The benefit from the exercise, it can be improve the osteopenia, sarcopenia, and the quality of life. So the evidence behind this, that there is a 28% lowering the risk of the flare at 6 months in 2,000 Crohn's disease patients. And another systematic review with a randomized control trial, they found that reduced disease activity with the physical activity. Reduce the disease activity with the physical activity. So the guideline recommend that exercise for all IBD patients, weight-bearing exercise for those at risk of the sarcopenia. So this can give us some idea about the importance of the exercise for the our patients. What about the specific carbohydrate diet versus the Mediterranean diet? This is a landmark trial called DINE CD trial. They include around 190 adult patients with a moderate to severe, with mild to moderate Crohn's disease. They randomized to 2 groups. One of the group, they took the specific carbohydrate diet, and another group, Mediterranean diet. 6-week prepared meal, then the 6-week self-prepared. So as you can see here, the result at 6 weeks, that Crohn's disease symptomatic remission between the 2 groups, around 46 versus 43. In the fecal calprotectin response, 34 versus the 30, and in CRB response, 5.4 versus the 3.6, and this is all statistically non-significant. So as you can see, there is no there is the specific carbohydrate diet is not better than Mediterranean diet in achieving the symptomatic remission, decrease the fecal calprotectin, and also decrease the inflammatory markers. What about the ignoring the risk of the ultra-processed food? This is a landmark pure study. They include more than 100,000 patients from 21 countries, and they follow up for more than 12 years. The dietary intake measured with the validated food frequency questionnaire. So the finding here is that ultra-processed food more than 19 grams per day versus less than 9, showing that there is increased risk of the IBD by 1.8 times, and also the packaged bread more than 30 increase more than 2 times IBD, and the ultra-processed more than 5 serving per day versus less than 1 increase the IBD risk reach up to the 4 times. While the fresh bread and the rice, it is showing that there is decreased risk of the IBD. So this is the guideline and the recent published guideline from the ECO. And this is a table that summarizes the dietary intervention in the IBD. So as you can see here, the only one recommended is the exclusive intranutrition as induction of the remission in Crohn's disease. The other colors, like the yellow color, it can be considered, and the red one is not recommended, and the blue color is insufficient evidence to recommend. What about the supplement? A supplement, as you can see here, there is no recommended any supplement, but can consider the curcumin and guandai for the ulcerative colitis as induction of the remission and maintenance of the remission. Conclusion, the nutritional therapy in IBD goes beyond the simple diet restriction. Use the exclusive enteral nutrition properly where indicated. Avoid unnecessary or unproven dietary exclusions. Recognize and manage both malnutrition and obesity. Correct the common micronutrient deficiency like the iron, vitamin D, B12, and incorporate exercise as a part of the overall management. Approach care with holistic, patient-centered strategy. Thank you very much.
Thank you so much, Dr. Ahmed Al-Ghamdi, for this wonderful, nicely presented data. Questions will be at the end of the session. Next talk will be about switching from IV to subcut formulations, top myths and mistakes by Dr. Turki Al-Amil. Dr. Turki is a consultant gastroenterologist at King Fahad Specialist Hospital in Dammam, Saudi Arabia. He's a graduate of King Saud University in Riyadh. He completed his internal medicine residency in Canada. It was followed by gastroenterology training at Western University and advanced fellowship at the University of Alberta. In addition to his general gastroenterology practice, Dr. Al-Amil has special interest in the inflammatory bowel disease. He serves as the board member of the Saudi Gastroenterology Association and is a former associate editor of the Saudi Journal of Gastroenterology. Dr. Al-Amil has authored several peer-reviewed publications in the gastroenterology and IBD field, contributing to the advancing clinical care and research in the field. Welcome, Dr. Turki. The stage and floor is yours.
Thank you so much, Dr. Hamoud. Thank you all for attending this morning, and thanks for the organizing committee for inviting me. And the task I was asked to perform this morning is to address myths and mistakes related to the use of subcutaneous maintenance treatments in patients with inflammatory bowel disease. So these are my disclosures. And I think the number one mistake is thinking that we're doing well with intravenous formulation of these medications in the long term. So some would say that we've been using IV maintenance for years, and if patients are doing fine, they're not complaining. If it ain't broken, why fix it? And I think this is incorrect. One of the major challenges we face in caring for patients with IBD is the cost of this horrible disease on our patients and the healthcare system. The fact of the matter is that it's expensive to care for these patients, not only for the cost of the medication, but also for the cost of their hospital visit, requirement for IV infusion, and the indirect cost coming with their absence from work and the need to visit the hospital frequently for maintenance infusion. So if you can avoid this by giving them subcutaneous formulation to be taken at home, you will be saving them time and saving the healthcare system money as well, which will improve their professional and personal life. Mistake number two, my patients with vedolizumab have been doing well with IV maintenance, and 100% of them are maintained on IV infusion. And I think this is a mistake, because with the approval of the subcutaneous formulation of vedolizumab, this option should be offered as a potential choice for these patients if it's available in your hospital. The approval was based on the Visible 1 and 2 trial. The Visible 1 was published in 2020 in gastroenterology by Bill Sandborn and colleagues. The trial included patients with moderate to severe ulcerative colitis who were enrolled and received open-label IV induction of vedolizumab 300 milligram at week 0 and week 2. And then at week 6, they were randomized to one of three arms: either received placebo, maintained on the IV formulation as usual, and the third arm was subcutaneous vedolizumab at 108 milligram every 2 weeks. At the end of 48 weeks, clinical remission rates were significantly higher in both arms of vedolizumab, the sub-Q and the IV, compared to placebo, giving it a positive nod as a potential option for managing these patients. Secondary endpoints, including durable clinical remission and clinical response, endoscopic improvement, were also met in this important clinical trial. When it comes to Crohn's disease, the Visible 2 had a similar design by Sabrine Vermeer and colleagues. Although she enrolled patients with moderate to severe Crohn's disease, they also received open-label IV induction at weeks 0 and 2. They were randomized to either placebo or subcutaneous maintenance. There was no maintenance IV arm in this trial. And again, vedolizumab sub-Q fared much better than placebo, 48% compared to 34.3% in the primary endpoint of clinical remission, defined as CDAI of less than 150. So again, vedolizumab was an option in patients with Crohn's disease to be given as subcutaneous formulation. So what practical approach can we give for our colleagues and be guided with? This is a very nice review article published by Sarah Horst and colleagues from Vanderbilt University in Nashville, Tennessee. So you have a patient with inflammatory bowel disease. They require treatment with vedolizumab as initiation. They receive 2 doses IV at week 0 and 2, and then at week 6, you start them on subcutaneous formulation every 2 weeks with follow-up clinical assessment. If your patient has been on vedolizumab for several years, for example, with IV maintenance, then ideally, before you switch them to the subcutaneous formulation, you would do disease assessment, making sure that they don't have a subclinical active disease. So you would do your non-invasive monitoring, you would do your endoscopic evaluation before switching them. If they are stable, you would go ahead and switch. If they have been maintained on the higher dose of vedolizumab every 4 weeks, IV infusion, consider doubling the dose of your subcutaneous formulation. Mistake number 3, my patient is willing to take subcutaneous formulation, but they are also insisting on subcutaneous induction, and we don't have new agents with this option. So although we had adalimumab, certolizumab, and golimumab as subcutaneous induction, some people think that we don't have the option for newer molecules, and that's not true. We have multiple agents as potential options, and the menu for options in managing patients with IBD is expanding, and we'll hear from Professor Mousli later this morning the new Saudi guidelines outlining the options that you can entertain for your patients. And some of these options will have the ability to be given as subcutaneous induction and subcutaneous maintenance. One of the important classes that were introduced recently is IL-23 inhibitors. They were used initially in patients with psoriasis with remarkable outcomes. These agents block the P19 subunit in the interleukin-23, and we have 3 approved in inflammatory bowel disease: mirikizumab, brisenkizumab, and gusellikimab. The first trial to show efficacy of these agents in IBD was the phase 3 mirikizumab trial, Lucent. They used IV mirikizumab at week 0, 4, 8, and then subcutaneous formulation. Following this trial, all other phase 3 trials followed the same way of IV induction for 3 doses, followed by maintenance subcutaneously. This was the case until the publication of Gravity in March of this year by Alicia Hart and colleagues from London, United Kingdom, and they looked at the efficacy and safety of inducing patients with Crohn's disease with gusellikimab subcutaneously. So they had patients with moderate to severe Crohn's disease. They were randomized to either receive gusellikimab sub-Q induction at 400 milligram at weeks 0, 4, 8, followed by maintenance, 2 options for maintenance, or placebo. And the trial met the primary endpoint of clinical remission rates at week 12. You can see that the delta was significant, reaching up to 56% clinical remission rates in those who received gusellikimab compared to 20% in those who received placebo. Interestingly enough, bio-experienced patients performed better than bio-naive patients, which is unusual in IBD advanced therapy trials. Endoscopic response was also better in patients who received gusellikimab sub-Q induction, again meeting the endpoints designed for this trial. Deep remission at week 48, that's clinical and endoscopic remission, was also superior in gusellikimab subcutaneous induction, followed by maintenance sub-Q compared to placebo. And this led the American College of Gastroenterology in their most recent guidelines to give you, as the practitioner, the option to either use gusellikimab IV induction or subcutaneous induction in patients with Crohn's disease. This also applies to ulcerative colitis, although the approval has not been gained by the Saudi FDA yet. In ulcerative colitis, the ASTRO trial had a similar design to Gravity, so they used subcutaneous induction in patients with moderate to severe ulcerative colitis. They gave them sub-Q gusellikimab, 400 milligram at week 0, 4, 8, followed by the 2 maintenance options. And again, The trial met the endpoints. Clinical remission rate was higher, regardless of the maintenance dose you choose. Symptomatic remission, endoscopic improvement, and clinical response was also superior in patients who received gizilokimab sub-Q induction followed by maintenance compared to those who received placebo. So when it comes to the menu of options, the selection can be guided by the clinical situation of the patient and the availability of the medication. Gizilokimab stands in a unique position where you have the ability to use an IL-23 with a subcutaneous induction. However, this unique position may not be held for a long time. Risankizumab trial is ongoing, looking at the efficacy of this agent in patients with Crohn's disease using a subcutaneous induction. This is the AFFIRM trial. It completed recruitment, and we expect the results sometime in 2026. And if this gains approval, the subcutaneous induction, it will be the second IL-23 with this option. Mistake number 4, subcutaneous infliximab is for patients who were stable on infliximab for years before switching to subcutaneously. This is not the case. The Liberty trial was published last year by Stephen Hanover and colleagues from Chicago. It looked at patients, 2 clinical trial programs, Liberty UC and Liberty CD. It looked at patients with moderate to severe inflammatory bowel disease. The medication has already gained approval in several jurisdictions, including the Kingdom, for use in patients with IBD. However, this trial set out to assess the efficacy compared to placebo. So patients with moderate to severe IBD were enrolled. They received infliximab IV induction as an open-label medication at weeks 0, 2, 6, and then at week 10, they were randomized to either continue on subcutaneous infliximab every 2 weeks or receive placebo. This is the data for Crohn's disease Liberty CD trial. Clinical remission rate were significantly higher in those who received subcutaneous maintenance compared to placebo. Endoscopic response was also significantly higher. And you can apply the same concepts to the Liberty UC. It met the primary endpoint and secondary endpoints. Even the stringent HEMI endpoint was higher in the infliximab subcutaneous maintenance group compared to placebo. One of the interesting papers looking at the use of subcutaneous infliximab is the paper by Schreiber and colleagues, which compared the pharmacokinetics of subcutaneous infliximab to intravenous maintenance. And what that paper showed is that you actually get better pharmacokinetics with the subcutaneous formulation compared to the IV formulation. Less trough, lower trough levels and high peaks after IV. With the sub-Q, you get a more steady state. And luckily, this steady state stands somewhere in the high teens to the 20 range. So if we have that high level, do we still need to combine infliximab with an immunomodulator to prevent immunogenicity in these patients? This is an important question that was assessed by Stephen Schreiber and colleagues in this post-hoc analysis of the Liberty program. And interestingly, the study showed no difference between those patients who received the combination of infliximab subcutaneously with an immunomodulator compared to infliximab subcutaneous monotherapy. So with this approach of maintenance CTP13 sub-Q, you can probably get away without giving your patient thiopurine with all the risks that we heard about yesterday from Professor Sharara and Dr. Ma'an Khattabi. The same data for ulcerative colitis, you actually get no difference with adding immunomodulator. And if you look at the drug level in this program, there was no difference between the pharmacokinetics in patients who received an immunomodulator compared to those who continued on infliximab subcutaneously monotherapy, whether they had underlying Crohn's disease or ulcerative colitis. And this extended to the 102 weeks of the trial program, the long-term extension of the Liberty phase 3 trial program. The data for switching existing patients, those who have been on infliximab for several years, comes from the important landmark study by the French group, the RIM Switch, led by Anthony Bissot. And they published their first paper in 2022, the RIM Switch, and they included 133 patients who were on maintenance IV infliximab and agreed to switch to subcutaneous infliximab. The majority of these patients did very well after a switch. 22 of them relapsed after the switch. The good news is even those who relapse, after escalation of the dose to double the standard dose, to 240 milligram every other week. They managed to recapture clinical remission in 94% of these patients and achieve combined clinical and biochemical remission in 80% of patients. So they gave you an exit strategy to recapture these patients if you lose response after switching. So who are the patients who are at risk of losing response? Well, if your patient had a high fecal cal before switching, then they are at higher risk of relapse after you switch to subcutaneous therapy. If your patient has been on a higher maintenance infusion of infliximab of 10 milligram every 4 weeks, then you should probably consider continuing them on IV maintenance or switching them to the higher dose of 240 milligram every other week. So this is again a suggested approach. You give the patient infliximab as a new therapy for the patient. They receive they receive intravenous at weeks 0, 2, and week 6, if you use the US label. The European label and the label in the Saudi FDA is 2 doses of IV. And then at week 10, they receive their first sub-Q maintenance treatment. They continue on every other week subcutaneous infliximab at 120 milligram of CTP13. If they have been on IV maintenance for years, then you may want to consider repeating the disease assessment clinically, biochemically, and endoscopically before the switch. Make sure your patient is in deep remission before you switch them. If the patient has been on 10 milligram every 4 weeks, consider switching to the higher dose from the get-go rather than going through the standard dose and then requiring escalation. Mistake number 5, my patient is obese and I'm worried about switching them to the fixed dose subcutaneous formulation, as they may relapse as opposed to the weight-based IV maintenance. This has not been the case from the RIM switch data. They published the data looking specifically at obese patients. The same study population included 21 patients with a body mass index more than 30. Around 6 patients had a body mass index of more than 35, so very obese patients. And what they found is that there was no difference in the risk of relapse when you compare those without obesity, with a BMI less than 30 on your left-hand side, compared to those with a BMI more than 30 or more than 35 in the middle and in your right-hand side. More importantly, the pharmacokinetics did not differ significantly compared to those with lower BMI. Patients with obesity had actually improved trough drug level compared to the time when they were receiving IV maintenance. Again, maybe mitigating the need for combining it with an immunomodulator. Patients were happier after switching. On the left-hand side, their acceptance for switching before they switched. On the right-hand side, their opinion after they already switched to infliximab sub-Q, and it seems that they were accepting this step and liking it. So again, emphasizing the point of giving them the option if you have access to the subcutaneous formulation. My patient has perianal Crohn's disease, and I'm concerned about using subcutaneous formulation because I'm not sure that it would work in this patient. This is myth number 6. And again, the RIM switch data questioned the rationale behind this myth. They looked at the same data set of 133 patients with infliximab IV maintenance who were switched. And among those patients, significant percentage had perianal disease. They assessed their perianal disease at 6 and 18 months. 40 patients had perianal disease. 92% of them had complex fistula. Significant percentage of them required drainage. 3/4 required ketone placement. So really a complex group of patients to manage when it comes to their perianal disease. And this is the result. On the top side of the slide, you see patients before switching to subcutaneous formulation. 3 patients in red with active symptomatic perianal disease. 1 patient in yellow with active disease on MRI and no symptoms. After the switch, the same patient with no symptoms remained. 2 patients remained with active disease. However, 1 had closure of their fistula and 1 had a fistula closed as well. So no significant worsening after 18 months of switching from IV infliximab to subcutaneous maintenance therapy. So to conclude, Mr. Chairman, vedolizumab subcutaneous therapy is effective in patients with inflammatory bowel disease after IV induction. Giselicamab sub-Q induction is the only IL-23 with approval to be used in patients with IBD. Subcutaneous infliximab CTP13 is a valid option in your patient with IBD, even those with obesity and those with perianal disease. Thank you very much.
Thank you, Dr. Turki, for the nice talk. Let me introduce our third speaker for this session, Dr. Mariam Mukhtar. She's an assistant professor and consultant of internal medicine and gastroenterology and IBD specialist at King Abdulaziz University. She obtained her internal medicine training and gastroenterology from the University of Toronto in Canada, and also she had her training in IBD fellowship at St. Mark Academic Institute and National Bowel Center in London, UK. Dr. Mariam, the floor is yours.
Thank you so much, Prof. Saada. Thank you so much for your attendance and for the invitation to speak at this conference. So my talk is about pouchitis and focusing again on myths and mistakes when it comes to pouchitis treatment. So I'll start with the background. So panproctocolectomy and ileal pouch anal anastomosis is a restorative surgery for patients who had their colon removed for various indications. It was first introduced by the surgeons Parks and Nicholas in 1978 and has since remained the preferred restorative surgeries both for IBD patients and for FAB patients as well. The J-pouch design is typically the most commonly used one, and because of the preserving of the natural route of defecation, patient typically has or have better quality of life, but that doesn't mean that they don't run into complications, both inflammatory complications and structural complications as well. So I'll start with the first myth, which is that pouches are less relevant to us in the biologic era. And the argument here is because of the advancement in the UC therapies and better care delivered to patients, that the colectomy rates are falling and therefore ileal pouches are less commonly used or constructed. But then to answer this, there are two or three parts to the answer. So first of all, the colectomy rates are actually increasingly dropped for elective colectomy, but not so much for emergency colectomy. And more than that, there is an increase in the incidence of UC and FAB globally, so there is still a growing population of patients. And we always have to remember that there are other indications, including colorectal cancers and dysplasias and other indications that are not so necessarily related to refractiveness of the disease. The second myth is to think that pouchitis rates are decreasing, and again, the argument is because of the advancement in therapy, we would expect a fall in the incidence of chronic pouchitis. Unfortunately, that is not the case, and this is what we've learned from a prospective large Danish study where they actually looked at the incidence of pouchitis in the first 2 years after the construction of pouches, and they divided patients into patients who had their surgeries from the 1996 up to 2000 in comparison to patients from the 2000 until 2018 period. And they saw that there is actually an increased risk, an absolute 15% increased risk of development of chronic pouchitis in the more recent years for unclear reasons. So the incidence reported for pouchitis in the literature is actually about 50% in the first 2 years of diagnosis, and about 80% of patients with pouches will have some pouch dysfunction or chronic pouchitis at some point in their time. The third myth I'll discuss is the oversimplification in thinking that the pathogenesis of pouchitis is just a simple inflammation, which is actually very different from the truth, which is that pouchitis is a very complex disease pathophysiologically. The prevailing theory still is dysbiosis and imbalance in the bacterial flora, but then you also have dietary factors. You have short-chain fatty acid deprivation. You have the bile acid exposure, and you have various mechanical and structural and surgically related complications as well that plays a role in the formation or incidence of pouchitis. The common mistake is, again, to think that all pouch dysfunction is chronic, primary chronic idiopathic pouchitis, which is actually the mistake we can run into if we do not carefully examine and investigate secondary causes of pouchitis and make sure to exclude alternative diagnoses, including Crohn's disease of the pouch or other causes, as you can see listed here. The common mistake is to miss pelvic sepsis as a cause of secondary or as a secondary cause of pouchitis. And in this study, you can actually see that more than a third of our patients thought to have idiopathic pouchitis actually had evidence of pelvic sepsis on MRIs. And it's very important to highlight the importance of MRI investigation when it comes to excluding pelvic sepsis as a secondary cause. The other myth is to think that any fistulae or fistulas, any stenotic complication in a pouch is a result of Crohn's disease of the pouch. And despite Crohn's disease of the pouch happening in the minority of patients, 2 to 8% of ulcerative colitis patients, the timing usually is what helps identifying or clarifying the fistula cause as being primarily related to surgical complications versus something that is actually truly Crohn's disease of the pouch. Now, when it comes to pouchitis presentation, unfortunately, it's very non-specific, but what you have to keep in mind is to specify and clarify the pouch function for each one of the patients you have. Typically, for a good pouch function, we say that patient will have an average of 4 to 8 bowel motions every day and 1 to 2 per night. So clarifying that and then basically seeing the increase in frequency and urgency is very important when it comes to the diagnosis of pouchitis in any given patient. The other myth is to think that symptoms are actually mirroring inflammatory severity, which is not the case when what the literature showed us. So in a study where they actually looked at patients with various etiologies of pouch dysfunction, whether it's Crohn's disease, whether it's cavitis, functional or chronic idiopathic pouchitis, and looking at the PDIA symptom score for all of these patients group, there was actually a huge overlap between all of the various causes. And the only specific symptom was actually bleeding for cavitis. It would still be a mistake to omit taking good and robust history because, as I mentioned, when it comes to the fistulas and stenotic complication, it is actually very important to establish two things. So has the pouch ever worked, yes or no? And what's the timing of complications and symptomatic worsening in relation to surgery? Because typically this is what will help us distinguish surgical from non-surgical related etiologies. It would still be a mistake to think because symptoms do not correlate with inflammatory severity on endoscopy, it still would be wrong to fail to appreciate the impact of symptoms on patients' life. From studies, we know that mental health issues in patients with pouch dysfunction are very common, whether it's depression, anxiety, or others. And sexual dysfunction is also a common problem that patients, both males and females, face. So the recommendation is to keep these patients monitored using mental health questionnaires and quality of life questionnaires and to routinely screen them for all of these complications. So we've said symptoms are not necessarily related to the endoscopic inflammation, but there is the same study actually showed that endoscopy is very useful when it comes to discriminating primary from other causes of pouchitis. If you can look at picture A, you see diffuse inflammatory changes in the entire pouch body in comparison to picture B, where you see a very regional and segmental involvement. So picture B is what you typically see when there is an ischemic pouchitis versus primary or secondary pouchitis. Another diagnosis that can usually be picked up on endoscopy is fecal stasis pouchitis. So this is what we call an efferent limb syndrome, where there is an obstruction of the outflow of the stool leading to stagnant fecal stasis in the pouch body and non-specific inflammatory changes in the both endoscopically and on histopathology. So unless you see the fecal stasis on endoscopy, you would miss this. Not recognizing cophitis would also be a mistake, because if you miss diagnosing cophitis, then you'll run into issues with refractiveness to antibiotics, because what we typically use for cophitis is mesalamine and topical therapies that we typically use for ulcerative proctitis. And another mistake is to not to systematically assess and report all pouch regions. So you have to know for each one of patients what the pouch design is. And you should be aware of the different segments of the pouch. And then when you report on the endoscopy, it's better to just report it segmentally. Whether you use endoscopic assessment tool like the PDAI, modified PDAI, or something like the endoscopic score of pouchitis or not, what is really important is to segmentally describe what you see. And there is the Chicago classification, which is actually unique in the sense that it is a phenotypically distinguishing classification system, dividing phenotypes of pouch into 7 phenotypes. And then what's also very important in this phenotypical description is that they have found an association between some of these phenotypes, including the diffuse inflammatory phenotype, the inlet stenosis, and the rates of pouch failures and need for pouch excision. Now I'm going to shift gears and talk about the management of acute and chronic pouchitis and what we have as myths and mistakes as well. So the first mistake would be to primarily routinely prescribe antibiotics or probiotics for patients to prevent first attacks of pouchitis. I'll focus first on the antibiotics. So the evidence actually comes from one randomized clinical trials on tinidazole that showed improvement in the pouchitis or reduction in the pouchitis risk. But then the overall body of evidence is very limited, and therefore the recommendation is actually against the use of antibiotics. And this recommendation also is backed, and the rationale for that is actually because of the good response. So more than 80% of patients would primarily respond to antibiotic in their first attack of pouchitis, and therefore there is no point of keeping them on primary prevention for something that is easily treatable, and the majority will respond anyways. Probiotics, the evidence is again from 4 randomized clinical trial. There is a little bit of uncertainty when it comes to single versus multi-strain probiotics. Again, the evidence is not very strong, and the same thing I just said about patients responding to first attacks beautifully is actually applicable to probiotic use in the primary prevention. And therefore, you can see that the AGA guidelines makes no recommendation whatsoever for or against the use of probiotics for primary prevention. When it comes to recurrent pouchitis, specifically antibiotic-dependent pouchitis, this is actually where we're talking about prevention with probiotic may be useful. So the suggestion is to actually consider using probiotic for patients with antibiotic-dependent and recurrent pouchitis. And then when it comes to chronic treatment for patients with recurrent pouchitis, the myth here is to also prolong antibiotic cycling and combination because of the thinking that it would effectively treat pouchitis in all patients. The common mistakes we run into is the over-reliance on antibiotics. And a secondary mistake is to also fail to reassess patients appropriately when they're kept on long-term antibiotics. You always have to screen these patients for the chances of the development of antibiotic-resistant organisms, development of C. difficile, and also you have to keep them monitored for adverse events, including tendinopathy when it comes to ciprofloxacin, or peripheral neuropathy in cases of metronidazole use. And you have to, again, regularly reassess and explore secondary causes for why they're not responding to antibiotics. We've had a beautiful lecture in the morning about the importance of diet, and this is also applicable to patients with chronic pouchitis. So there has been different studies. The overall literature is still limited, but there is some suggestion that increased fruit and antioxidant use is preventative from development of pouchitis. There is some evidence for Mediterranean diet, Crohn's exclusion diet. So you would want to optimize patients' dietary factors in your attempt to control the recurrent disease. You need to also provide them with minerals and supplement them with vitamins as needed, because we know that they commonly run into issues with vitamin and mineral deficiencies. The other mistake is to omit the use of budesonide, although it's an effective, whether it's topical, whether it's oral, it's an effective and well-tolerated medication. So you would want to give your patients a chance when they're not appropriately or only partially responding to antibiotics. You would want to trial them on budesonide. And the important myth here is to think that advanced therapies have no role in the treatment of chronic pouchitis. Various studies have been conducted, mostly observational studies for most of the biologics, but then vedolizumab is actually the approved agent based on the EARNEST trial showing efficacy of vedolizumab in treating chronic pouchitis. The mistake when starting biologic would be to forget to exclude pelvic sepsis first and then run into issues with worsening pelvic sepsis if this is not excluded. It would also be advised to always consult with your surgeons and bring these patients' discussion into MDT and see if there are any alternative treatment. Ongoing assessment and for effectiveness and quality of life is also needed, and you have to set very clear targets and goals with your patient and serially assess your situation. It would still be a mistake not to consider a biologic medication because it had previously failed for this specific patient prior to the colectomy. So if a biologic failed prior to colectomy, that does not preclude you from using it after the ileal pouch is created. Thinking that because ulcerative colitis is treated with the pan-proctocolectomy, that monitoring ends is also a mistake. Although there is no consensus when it comes to the frequency of surveillance for patients with pouches, you have to individualize this and you have to put in consideration all of the patient-specific risk factors when it came to prior colectomy, dysplasia, FAP, or whatever indication he has, and then keep them monitored for dysplasia and colorectal cancers. The last mistake I'll end up with is to manage patients with pouch dysfunction out of tertiary hospital care or out of a specialist center. And this is because even with all of the advancement and all what we can provide our patients with, we still run into issues with pouch dysfunction, pouch failure, and there is a 6% chance of the need of pouch revision or pouch excision. So frequent assessment of patients and discussing with between the gastroenterologists, surgeons, dietitians, and psychologists and psychiatrists is very important when it comes to actually managing patients' quality of life and ultimately choosing what's best for this patient. But the message is to have your patient followed as a tertiary hospital if they have pouch dysfunction, where the IBD surgeons are around. And this brings me to the end of my talk. Thank you so much for your attention.
Thank you, Doctor, for this nice presentations. Our next speaker is Dr. Dana Isa. Dr. Dana is a specialist of gastroenterology and hepatology at Jabal Ahmed Hospital in Kuwait. She started her residency at University of Queen in Kingston, Canada, and then she continued and switched to University of McMaster to do her residency in gastroenterology or fellowship in gastroenterology and subspecialty inflammatory bowel disease. So please, Dr. Dana.
Good morning, everyone. Thank you, Dr. Ahmed, for the kind introduction. So I was asked to talk about management of inflammatory bowel disease with concurrent infections, myths and mistakes. So we're going to go over these points. I'm going to just move for time. So first of all, I want to point out that not all opportunistic infections are serious, and not all serious infections are opportunistic. And by this, I mean that opportunistic infections, by definition, is infection that is caused by a microorganism that has limited or no pathogenic ability under normal or ordinary circumstances, versus serious infections that can lead to a hospitalization or actually the need of IV therapy, and that may take the patient to a death or disability. And that's very important to highlight for my next slides. So, does that mean that all patients with IBD are immunosuppressed? And the answer is no. Not all IBD patients are immunosuppressed, but they do have different risk factors that actually interplay and put them at risk for infections. And by this includes malnutrition, if they're old in age, if they have other chronic diseases, and if they have, and then they use immunosuppression such as steroids or certain advanced therapies, and their disease activity actually puts them at risk for infections. But it's always challenging. The mistake is when it comes easy to diagnose infection in patients with an IBD, but actually it's challenging because is it a direct effect from the immunosuppression therapy that they're on, or is it an adverse event from it, or is it disease activity that's put them at risk for infection? So this is the table that most of us are familiar with. It tells us the degree of immunosuppression on certain medications that our IBD patients are on. And this takes me to my next slide. Is it true that all immunosuppression therapy and biologic agents increases the risk of infections? But no, the answer is that the data is conflicting. There are studies, and such as the SONIC trial, which is one of the biggest trials, that tells us that there is no difference between thiopurine alone versus anti-TNF alone and the combo therapy when it comes to the risk of serious infections, versus also other data and retrospective case controls and prospective studies did show that there is an increased risk of infections when it comes to anti-TNF, steroids, thiopurines, and also combination therapies. But what about Vido, which is a gut-selective medication that we always use and refer to as a safe gut-selective that does not put the patient at risk of infection? It did actually show that there was no increase in opportunistic infections. However, they did highlight that it may be associated with C. diff infections. This is a meta-analysis that included 15 studies that looked at the risk of serious infections with anti-TNF as monotherapy versus anti-TNF combination therapy versus thiopurine alone in IBD patients. And they did find that actually when they compared anti-TNF versus anti-TNF combo therapy, there was actually a higher risk of serious infections. And then when they looked at the immunosuppression therapy as a monotherapy versus anti-TNF monotherapy, they found that actually there was a higher risk when it comes to anti-TNF as monotherapy. And they highlighted that actually when it comes to an anti-TNF based therapy, it was actually associated with a higher risk of infections. We're going to move to certain clinical related infections, and we're going to highlight most of the myths and mistakes when it comes to treating them with IBD. So one of the commonest that we face in our clinical practice is C. diff. IBD flares and C. diff have completely different symptoms. And C. diff can always be distinguished from IBD flare by a colonoscopy. Is that true? That's definitely not true. So the incidence of C. diff in IBD flare is around 9%, and actually patients with IBD are 8 times more likely to be colonized with C. diff, and they do actually resemble IBD flare. So it's difficult to distinguish between a C. diff and an IBD flare, and you rarely see pseudomembranes on colonoscopy. So that takes us to our next point, which says that all patients with IBD that are hospitalized with a flare should be tested for C. diff, and even those who present with diarrhea while their disease is quiescent, but they do have the risk factors, they should also be tested for C. diff as an ambulatory patient not hospitalized. So when it comes to the pathogenesis or the risk factors for C. diff in IBD patients, when you talk about a typical non-IBD patient, those are the elder patients that are exposed to antibiotics, that are more common or often has a recent onset hospitalization. But on the other hand, when you look at the IBD patient, these are younger patients. They are less likely to be exposed to antibiotics. They're actually in the community, not hospitalized. And they do have active disease. So you need to think about C. diff testing in these patients, and not only the classical C. diff patient that is not an non-IBD. So when it comes to testing, and maybe this might be misleading in certain reporting in different institutes, because if the report actually tells you there is toxin PCR, that doesn't tell you that the patient has a C. diff, an active C. diff infection. That's just colonization. So we need to focus on the toxin itself. And by this means that we need to treat C. diff actually before thinking about adjusting our IBD therapy itself. So this is from the AGA guidelines, and what it says actually, when a patient has a C. diff infection, not a colonized one, but when they do have a positive C. diff, then you treat them with their first line of therapy, which is vancomycin or fidaxomicin, based on what you have available in your institutes, and then you monitor your patient. If they're improving, good, you continue with your immunosuppression therapy. However, if the patient is actually not improving and is showing signs of active colitis or active disease, then you need to think about your underlying IBD active disease, and you need to start thinking about escalation of therapy or adjusting your immunosuppression therapy at that point. What about the duration of your therapy in the setting of a C. diff infection in IBD patients? That's a study that showed, that compared actually the standard duration, which is 10 to 14 days, versus the longer, 21 to 24 days of vancomycin study. And they did actually notice that there was a decrease in recurrence and reinfections of C. diff infections in those patients who were treated with the longer duration of vancomycin versus those who were treated with the standard duration. We're going to move on to the cytomegalovirus, which is actually known as the innocent bystander. Is it always an innocent bystander in an acute severe UC flare? And the answer is no. But when do you need to think about it actually and take it seriously and treat your patient for CMV colitis? Those patients who have risk factors, such as old patients who have steroid refractory or on high doses of steroids that are not responding, those who have severe pancolitis, a high burden of inflammatory markers, elevated CRP, elevated fecal count, those patients need to be tested, and if it's high, and we're going to talk about it in a bit, then needs to be treated for. So how do you diagnose? The mistake that we might run into is that we check them for CMV viremia, and it's only 30% of IBD patients who actually have positive CMV viremia. So the methods of choice when it comes to diagnosing CMV colitis, it's by H&E, immunohistochemistry, and tissue PCR. And that would make a difference when it comes to the decision of treating or not treating the CMV colitis in IBD patients. They usually have ulcerations on colonoscopy when you scope them or do a FLIXIG on them during their acute flare. And why does it matter when it comes to diagnosing and actually treating or acting upon your results? Because those patients who have CMV colitis are actually at high risk of having colectomy, death, and increased healthcare use. A meta-analysis actually did show that there was a reduction in the risk of colectomy by 80% in CMV positive UC patients who were resistant to corticosteroids. So that's a meta-analysis, or actually a study that was done at Mayo in more than 50 patients with IBD and co-infections with CMV. And they looked at specifically at the inclusions on biopsy, and they actually acted upon the number. So patients who had low inclusions, 1 to 2 per biopsy, were treated, and those who had higher also inclusion biopsy were treated. And they noted that those with high inclusions that were treated did have a reduced risk of colectomy, but they did not see this difference when it came to the patients who had low inclusions and that were treated. So this tells us that high tissue viral load or inclusions actually matter, and it is the culprit for the gut inflammation. And at that point, you need to think about treating this patient and acting to reduce their risk of colectomy and the high burden they would have. So what should you do? So first of all, you need to make sure that the patient does not have CMV viremia, because this would change the course of treatment. However, if the patient only has CMV colitis, then you need to start thinking about tapering off your steroids and starting them on their antiviral, which is initially as an IV and transitioning them on an oral antiviral. And think about your like current use of the biologic that the patient is on. What are they on? Is it controlling their disease, or do you need to change therapy? So this needs to be assessed as per patient. We're going to move on to hepatitis B. Is hepatitis B reactivation a risk underestimated in IBD patients? It is very important to actually identify those patients and treat them prior even to starting them on their immunosuppression therapy. So the risk of hepatitis B reactivation is classified into three. There is the low risk, which is less than 1%. There is the intermediate risk, which is 1 to 10%. There is the high risk, which is higher than 10%. And by this, you need to actually do a combination of serological markers, including hepatitis B DNA, hepatitis B surface antigen, and hepatitis B core antibody. And this will tell you which patient risk is their patient at. So this table identifies the risk of hepatitis B reactivation with IBD immunosuppression therapies, and on this table I highlighted the medications that we commonly use in our patients. And you can tell from the table here that we have the high risk, moderate risk, and low risk. And by this, you identify them by their positive surface antigen or negative surface antigen and the core antibody. And then the other column there, you can see the surface antigen negative and the core antibody positive. And this actually will change how you approach your patient. So if you have a patient who is on anti-TNF, but the serology is actually different. So if you look at the moderate risk, you find that anti-TNF under surface antigen negative and core antibody positive is actually moderate risk. But if you look at the surface antigen positive and the core antibody positive, it is actually a high risk. So this would alter your treatment. And here, there's a bit of discrepancy in the guidelines, and I specifically highlighted the anti-TNF because the AGA actually recommends prophylaxis for moderate risk of surface antigen negative and core antibody positive patients, but actually the EASL guidelines said maybe you can actually monitor and treat when needed or if it's feasible. So I think it depends on the hepatologist you work with if you refer them to your hepatologist, but how would you do that is actually you have to start them on treatment 2 weeks before the introduction of immunosuppression therapy, and this should be continued for at least 12 months after immunosuppression withdrawal, and only discontinue if the disease is under remission. We're going to move on to the commonest thing that maybe we face, actually I do face in my clinical practice, is when is it the best time to test your patient for latent TB? Maybe it's easy said than done. We have a patient that is newly diagnosed with IBD, you do your pre-biologic workup, you have them ready, but then you have the other patient on the other hand. They present with an acute severe UC, they're not on biologics. You bring them into the hospital, you requested your pre-biologic workup, and then actually this patient does not get your TB test. And then on day 4 or 3, when you want to take an action, you find that this patient actually had a late TB test done. And it comes back as positive. Does our medication alter the results of the latent TB testing? And the answer is yes. Baseline TB testing prior to immunosuppression therapy actually is affected. So testing for the latent TB by quantiferon or a TB skin test is affected by also disease activity. So this is a study that looked at both quantiferon and TB skin test, and they found actually that quantiferon is less likely to be affected and is actually consistent with It is actually consistent even if the patient has a PCG status, they have a lower false positive, and it's a one single visit, office visit to get it tested. And this is another systematic review and a meta-analysis that looked at the impact of immunosuppressive therapy on latent TB screening in IBD patients. They looked at both IGRA and TB skin tests, and they found that both of them actually were negatively influenced by immunosuppression therapy. However, they found that the rate of IGRA negative and the skin test positive tended to be higher than the IGRA positive and the skin test negative. The immunosuppression therapy does decrease the IGRA positive rate and increase the IGRA indeterminate rate. So we need to be careful when it comes to testing our patients on steroids or the advanced biologic therapy. So what does the CDC and other infections societies recommend? They actually recommend dual strategy when it comes to testing for latent TB by IGRA and the TB skin test. And if positive, then of course you need to refer them to an ID or respirologist. If they have latent TB, then you need to delay your treatment for at least 4 weeks after TB treatment and get the approval of the ID or respirologist to start them. But if they have active TB, then you need to delay it for at least 2 months after anti-treatment with full compliance until the drug susceptibility profile is actually positive and known. And this takes me to the end of my presentation. Just to conclude is that IBD patients are at elevated risk of infections, particularly under immunosuppression. Most infections can be effectively treated with timely intervention. Accurate interpretation of results in clinical context is crucial for management. Tailored immunosuppression therapy to balance efficacy and infection risks. Thank you.
I think we're going to start having the questions. Can we invite the speaker just to join with us here? Yeah. Can we have the mic?
Excellent talk. So, 4 presenter, 4 questions, right? So we start by Ahmed. Where is Ahmed?
معلش أبو أيمن, I'm afraid he had to leave. He had a commitment to Dr. Ahmed Al-Ghamdi, so he left.
Okay, that's fine. Skip one question.
I was wondering if the panel can help me in Ahmed's question. When you say enteral feeding, NG tube enteral for 12 weeks and non-emulsifier. So that's a question to Ahmed. What shall I tell the dietitian about the enteral feeding? This is number 1. And number 2 is the practical point in a busy clinic. When you see malnutrition, what advice you give Crohn's small bowel patient quickly until he sees the dietitian about the diet, the type of diet, what to avoid, and the supplement. And if I remember Dr. Abdulillah, he gave that oral zinc, in the era of Corona, everybody was taking zinc. Does that help in reducing the flare of Crohn's? This is for Ahmed. Anybody can, from the panel, or can add any point? Umar, regarding enteral feeding, maybe in children, enteral feeding?
In children, we use enteral feeding for induction of remission in Crohn's. And it's a liquid formula for 6 weeks.
And then it has to stay in the hospital, or he can go home with this?
No, he can have it at home.
Okay.
But
Emulsifier?
it's exclusive liquid formula.
Liquid food. Okay. Supplements?
Polymeric.
Okay. The question for Turkey is regarding the sub-Q now. Everything is getting a patient on IV. Suppose the patient on vedolizumab, and he's on 300 every 4 weeks. That also comes with the perianal disease. You don't shift to sub-Q, or you shift?
No, I would shift actually. The point when I said perianal disease was a mistake, thinking that you cannot shift patients. I would still shift these patients. to subcutaneous. The pharmacokinetics is better. If the patient has been on IV vedolizumab 300 milligram every 4 weeks, you may consider the higher dose of 108 milligram sub-Q every week instead of every 2 weeks. Yeah.
Every week. Question to Mariam regarding pouchitis, and you give the patient antibiotic, and then the question comes, for how long should I give ciprofloxacin? What is your recommendation? What do you give for pouchitis? 1, 2, 3, and for how long?
Okay, thank you. So for pouchitis, so it depends. So if it's acute pouchitis, typically 2 to 4 weeks of either cipro or metronidazole.
Not combination?
If it's the first attack, it's typically one of the two. If it's chronic antibiotic
Cipro, how
dependent,
much? 250 BID?
No, it's 500 twice daily. Then if it's chronically antibiotic dependent and you're keeping them on chronic suppressive therapy preventively, it's the 250 BID or the 500 once daily. You would want to cycle the antibiotics and then potentially skip 1 week of no treatment just to prevent the long-term complications and to avoid antibiotic-resistant organisms. And so it depends on the patient's response. If you can taper them off and take them off antibiotics, so you typically do the 4 weeks and stop. And if not, then it's these chronic suppressive cycling therapy between antibiotics and eventually advanced therapies or immunosuppressive medications.
So do you give flagyl later? If
You can switch between. So we know that cipro is actually better tolerated, but you can treat patients with cycling. So 2 weeks or 4 weeks of one antibiotic, you skip 1 week and then you cycle on the other one.
Excellent.
You can also consider combination for patients who are partially responsive to either one.
And budesonide or any local 5-ASA?
Yes. Yeah, definitely. Local mesalamine, if there is no cophitis, not so much. But if for the budesonide, definitely yes.
Excellent. Excellent. Dana, excellent. The question comes always with the CMV. Patient comes with flare. You do the biopsies. We are not lucky like King Faisal. They have 5 gastropathologists. But they tell you the CMV, IgM is negative, the PCR is negative, the tissue. But you see a lot of inclusions. The copies are in between, and he's not a gastropathologist. And you wonder, do you treat or you don't? And do you stop the biologic? What is your rationale if you don't have a gastropathologist?
I think it's tough, as you said, if you don't have a gastropathologist, but also the clinical picture matters. If someone who comes in to you who's sick, who needs an admission, who you go in with a scope and found ulcerations, and then you put it in a clinical context, and probably you would treat if it comes back positive, but...
PCR tissue negative.
PCR is negative and has inclusions or no inclusions?
There is inclusions.
Is it low or high?
Low.
So if it's high, I would treat.
Okay.
Low, probably you want to think about the whole clinical picture. But usually it recommends if they have a high inclusions and high viral load or a tissue PCR, then these patients you would treat.
I have a question for Dr. Mariam. What's your thinking when you decide to go for advanced therapy or biologics? How many courses of antibiotics? What's the proper workup or plan just to achieve the decision to start biologics?
Okay, thank you so much. I don't think there is a clear, fixed plan for all. So it's individualized. You have to factor in the patient's quality of life, how symptomatic they are, how bothered they are by the symptoms. And then you properly counsel them, give them the options. I would give it probably early on. If the patient is antibiotic dependent, or obviously if he's antibiotic refractory early on. But it's not a one-size-fits-all. It has to be individualized to the patient goals of care, like his quality of life, what actually he wants or aims to achieve, and then the availability of biologic treatment. You have to also factor in how refractory the pre-surgery or pre-colectomy disease was. But then it's a dynamic, like the MDD discussion and patient counseling and so on.
Can we just give a chance there and then we go to Dr. Hamad?
Stand by, Hamad.
Yeah.
Thank you very much. I'm Dr. Abdurrahman Kanan, GI consultant, Jeddah. My question to Dr. Adana, how much common you are looking for common variable immune deficiency syndrome as a risk for recurrent relapsing IBD? Because the last month I have a patient who came 3 times in a month with relapsing, and after consultation, a senior guy, we checked the immunoglobulin, it was very low. Then we treat our patient with immunoglobulin. So how much in your experience you see such cases, and when you will look for the common immune deficiency syndrome as a risk for recurrent infection or recurrent relapsing for patients with IBD?
I think it differs from one patient to another, but as you mentioned that if a patient is not responding, then these patients you need to think, especially our patient, they're actually at risk of having infections because of their immunosuppression. And if the patient has chronic use of steroids in the past, then these patients you need to think about actually testing them as you did. It's not an easy actually decision to take unless these patients do not respond. Then I think that's the time then you need to think about immunoglobulin deficiencies and even like opportunistic infections.
Yes, Dr. Hamad. It's here.
Regarding C. diff, ulcerative colitis flare, you take a biopsy and it comes back positive, and for how long you treat, and then you become in a dilemma. Did I clear it or not? How do you follow? How long you give, and how do you follow these patients?
So the clinical symptoms matter. If you treat them, so it's hard. Let's move it that way. Because they both have diarrhea, right? So if you treat them, they're improving, looking at other markers or inflammatory burdens, then you need to think about your IBD disease itself and the disease activity, and you need to act on your immunosuppression therapy versus the C. diff treatment by itself. Did I make it clear or no?
So for how long, and how do you clear, apart from clinical,
So
how
usually, so they can be colonized. You cannot clear them because you cannot test them. If they're doing well, don't test them because they'll be colonized. That's what I highlighted. When it comes to testing, what's on the report is actually important. You don't need to see just a C. diff positive because you want to know, is it a toxin? Is it a PCR? Because that makes a huge difference. You don't want to treat C. diff infection while the patient actually has active disease. And it's not the C. diff that is driving it. It's the inflammatory burden of the disease itself that's driving it.
Yeah, we have a question there in the back.
Yeah, thank you. This question to Dr. Turki has been mentioned in lectures. The obesity in subcut infliximab, the maximum BMI was 35. Do you consider this as in our community or US-Canada obesity? It looks like this maybe obesity was done in other countries where their obesity is 35 is high. So I think we need more study for this obesity because we have obesity BMI above 69 in IBD or above 50s, and maybe the dose, we don't know it will act or not. What do you think?
No, I agree with you, Dr. Mahdi, and I think you raise a very good point that this was an observational data from a different population, a French population. They included 21 patients. But I know you have you're working in a center managing obese patients, and you have vast experience in managing patients with IBD. So I totally agree with you. I think we need to look at data from our population, particularly in extreme BMIs above 35.
If I have a comment, just like, I think even also in general, obesity is a big problem now in IBD patients because the response to biologics is less, the inflammatory process with the fat accumulation is higher. So there's a clear evidence that it's effect, but switching from sub-Q, that's as you mentioned, it's very important to be studied well.
Yeah, so definitely. So with all monoclonal antibodies, obese patients tend to lose response quicker than patients with normal body mass index. It may not be the case with small molecules. It seems that BMI does not affect the outcomes with small molecules, but definitely it's something not only for the response to biological therapy, but for the overall health of the patient. We need to advise them to lose weight.
You have any further questions, any comments?
I have a question for Dr. Turki. For patients who are eligible to be shifted from combination of infliximab and azathioprine, and they are going to be shifted to the subcut, if the high-risk population with the perianal disease, with stricturing, penetrating, what is your recommendation regarding the azathioprine in the long term?
Yeah, so this is a good question. I think in this particular group of patients where you failed multiple lines of therapy in the past, it would be reasonable to continue on combination therapy. As you know, the SPARE trial by Edward Louis and colleagues looked at withdrawing immunomodulator after 6 to 12 months of treatment. However, this trial excluded patients with perianal Crohn's disease. So I think to your point, these patients have refractory disease when they lose a response to multiple lines of therapy, or if they have poor phenotypic behavior of the disease, then maybe there is a point in continuing immunomodulator long term.
If we don't have any further questions, I think this will... Oh, there? Oh, can you have the mic there?
My question is from Dr. Turki about the subcut infliximab in perianal disease. You showed some data about switching and maintaining the good fistula outcomes. Would you extrapolate this data to start somebody who is a new diagnosis with perianal on subcut directly?
Yeah, so that's a very good question, and I think I showed the data for the RIM switch where you switch existing patients. However, the Liberty CD phase 3 trial included patients with perianal Crohn's disease who were started with IV induction for 3 doses, then switched to sub-Q. And to the bigger picture, if you look at the bigger picture, the Schreiber paper shows that the pharmacokinetics is actually better with subcutaneous, with higher trough levels in the high teens to 20 range, which is something desirable in patients with perianal Crohn's disease. So I think I'm very comfortable using it in patients with perianal Crohn's disease.
Okay. Further questions, comments? I think this would end our...
Yeah. Thank you so much. I think we have a note from the organizers. We have a 20 minutes break now, and then there is another break at 12 o'clock. There was a typo mistake saying that it's 1 hour. It's actually 20 minutes. So 20 minutes now, 20 minutes at 12 o'clock, and then we'll resume the afternoon session 12:30. Now we'll resume after 20 minutes. Thank you.
كم دي كيف سويت
نبدأ. السلام عليكم ورحمة الله وبركاته. I would like to welcome everybody in the hall for the fourth session of the meeting, second session of the day. I'm getting this opportunity to thank all the members of scientific committee and organizing committee for doing this wonderful job and giving us this fantastic meeting and great science. Without further ado, I would like to introduce my co-chair, Dr. Fatma Al-Alawi. Fatma Al-Alawi, she's from Al-Bahrain, consultant gastroenterologist and IBDologist in Ivixia Hospital. And Dr. Hamad Shuja Al-Uthmani from King Fahad Hospital, Jeddah, and senior consultant gastroenterologist. So without further ado, I would like to invite the first speaker of today, talking about guidelines or updating guidelines, new guidelines. It's like a surprise talk by Professor Mahmoud Musli. Professor Mahmoud Musli, a well-known gastroenterologist, professor of medicine in King Abdulaziz University Hospital. He's IBD specialist, IBD researcher, and one of the leading in the field with over 70 publications in the field. So, Dr. Mahmoud, the floor is yours, please.
Good morning. Thank you, Dr. Khan, for the kind introduction, and I'd like to thank the organizing committee for allowing me to give this talk. So this is actually the official unveiling of the updated 2025 Saudi inflammatory bowel disease practical guidelines for the medical management of adults with moderate to severe inflammatory bowel disease. So these are my disclosures. I think we all understand the necessity to have guidelines for IBD. Inflammatory bowel disease worldwide has become a global challenge, let's say. From a medical standpoint, the burden extends to the societal level and has a great impact on the quality of life. Of course, if you had attended yesterday's talk by Dr. Badr, he nicely highlighted what's been going on in the kingdom over the past 2 decades. You can see that there's a 5-fold increase in the IBD incidence. Previously thought to be rare is now quite common. UC incidence is estimated to be about 2.33 per 100,000 person years in the Arab world. And for Crohn's disease, it's 1.46 per 100,000 individuals. Of course, the presentation and associated morbidity among Saudis is fairly comparable to data from Western countries. So why do we need guidelines? Saudi IBD specific guidelines. Number one, due to the rising incident, as I mentioned. Number two, the need for standardization of practice among gastroenterologists and treating physicians. And we need to endorse following evidence-based care, which is the best way to guarantee favorable outcomes for our patients. Now, there has been previous iterations of the Saudi guidelines. The first one published was in 2022. And this was actually for adults and was a very comprehensive document that detailed steps in diagnosis and management of the full spectrum of diseases. This was a result of a collaboration between Ministry of Health, Saudi Gastroenterology Association, and the Saudi Society of Clinical Pharmacology. It presented 78 consensus statements with lots of details. In 2024, a guideline document focused on IBD during pregnancy was published. So this gave us management and care pathways with the same collaboration. 23 statements and a clinical care pathway was presented. And finally, early this year, pediatric and adolescent IBD guidelines were published, focusing also on diagnosis and management, and gave us 57 guideline statements. Now, what is different? How is this new guidelines I'm about to present different from the previous one? First of all, this is only focused on the medical management of moderate to severe disease. So we do not talk about mild disease anymore, and we're not talking about diagnosis. So this is a fairly focused iteration of the guidelines. And there's expanded therapeutic options presented, so inclusion of new biologics, small molecules, inclusion of biosimilars, a clear positioning of anti-TNF versus newer therapies. There's stronger evidence-based approach adopted to put together these guidelines, so recommendations aligned with the latest international RCTs and meta-analysis, and there's more emphasis on treat to target and mucosal healing. There's sections that are disease-specific, stratification. There's separate detailed algorithms for Crohn's disease and ulcerative colitis, updated risk stratification and treatment sequencing. In this guidelines, we put a lot of effort in local adaptation, so integration of Saudi-specific epidemiology, resource availability, and MOH referral pathways in alignment with the SCHS fellowship and clinical training needs. Multidisciplinary and patient-centered care are integrated into the guideline document. The expanded role of IBD nurse, dietitian, and psychologist is mentioned, and there's a stronger focus on the quality of life and patient-reported outcomes. So this is the methodology we adapted. So for the panel composition, these Saudi IBD guidelines were developed in collaboration again with the Ministry of Health, Saudi Gastroenterology Association, and the Saudi Society of Clinical Pharmacology. The panel comprised of 2 dedicated methodologists, 14 clinical experts with extensive IBD experience, including mostly gastroenterologists and a few expert clinical pharmacists. Evidence synthesis, the methodology team performed an independent systematic literature review across major clinical medical databases. What we included were meta-analysis, RCTs, non-randomized studies between 2015 and 2025, and quality assessment was done using standardized tool. We adopted the grade approach, which was used to evaluate evidence certainty. So classifying it as high, moderate, low, or very low. Recommendations were formulated based on thorough risk-benefit analysis, quality assessment of available evidence, and the collective clinical expertise of the panel. Formal approval required a minimum consensus threshold of 70%. So again, these are the goals we had set forth when we put together these guidelines. Again, standardized approach, optimized treatment, improved outcome, and local context inclusion. This is a very important, understanding the recommendation strength classification. So a strong recommendation means the benefits of the intervention clearly outweighs the risks. The quality of the evidence here is high, and clinicians should follow this recommendation in most situations. Patients can be confident in the benefit of the intervention with strong recommendation. However, conditional recommendation means the benefits of the intervention still outweighs the risk, but the quality of evidence is lower, or there is some degree of uncertainty. Clinicians should consider this recommendation, but the individual patient's circumstances and preferences should guide decision-making. Finally, you will find in this document a few good practice statements. So evidence in this case has been deemed by the panel as insufficient to recommend for or against the intervention, and it was placed as a consensus based on the expertise of the panel. Clinicians in this case should use this judgment and consider patient preferences, but further research is needed to clarify the effectiveness of this intervention. So understanding this is very crucial for informed clinical decision making. So let's start with Crohn's disease, so moderate to severe Crohn's disease. So the first part of the guidelines, you'll find there's a section on initial treatments for bio-naive adults with moderate to severe Crohn's disease. So the guidelines, we highlight early initiation of therapy. So there's a strong recommendation for early initiation of biologics therapy over no treatment with moderate certainty. Anti-TNF agents, which is considered a pillar in the treatment algorithm of these patients. So there's a strong recommendation for anti-TNF agents. So infliximab, adalimumab, certolizumab pegol over no treatment with moderate certainty. Finally, there's a strong recommendation for other biologics, so specifically vedolizumab, ustekinumab, and anti-IL-23 agents, risankizumab, guselkumab, over no treatment with moderate certainty. Now, in case of patients who are advanced therapy exposed, we talk about secondary loss of response to anti-TNF therapy. So for CD patients with secondary loss of response to anti-TNF, not primary failure due to the development of anti-drug antibodies, the guidelines conditionally recommend switching to another anti-TNF agent over switching to another class of medication. For non-responders, despite adequate drug levels, so here the recommendation is conditionally recommended switching to an advanced therapy outside of the anti-TNF class with low certainty evidence. Now, with regards to anti-IL-23 versus anti-IL-12/23 inhibitors, the guidelines strongly recommend using an anti-IL-23, so risankizumab or guselkumab, over anti-IL-12/23 with moderate certainty evidence. Risankizumab specifically demonstrated superior efficacy outcomes compared to ustekinumab after 24 and 48 weeks of follow-up. Moving on to upadacitinib, the only JAK inhibitor approved for Crohn's disease. So here, UPA is strongly recommended over no treatment for induction and maintenance in moderate to severe Crohn's disease. As we know, upadacitinib has been associated with higher clinical remission versus placebo and higher sustained remission up to 52 weeks, and should be considered for patients with inadequate response to biologics. There's a section that really outlines and highlights choices of combination therapies for patients with Crohn's. And when we talk about combination here, we talk about the dynamics of using concomitant immunosuppression, specifically with anti-TNF agents. So for example, we conditionally recommend infliximab combined with an immunomodulator over infliximab monotherapy for induction of remission with moderate certainty. With regards to subcutaneous infliximab, we recommend or conditionally recommend subcutaneous infliximab monotherapy over subcutaneous infliximab with an immunomodulator for maintenance of remission. With regards to adalimumab, conditionally recommend adalimumab monotherapy over adalimumab with an immunomodulator for most patients with moderate certainty. And the reason behind that is that for adalimumab, there was no significant differences between patients who received adalimumab and thiopurine combination therapy and adalimumab monotherapy regarding induction of remission and clinical response. However, combination therapy was associated with lower immunogenicity but potentially higher long-term malignancy risk. What about treatment optimization strategies for Crohn's disease? We talk about therapeutic drug monitoring. So for adults with Crohn's disease and secondary loss of response to anti-TNF, the guidelines conditionally recommend measuring anti-TNF trough levels and optimizing the dose based on these levels, rather than maintaining the standard anti-TNF dose without trough. Without trough level monitoring. This is with very low certainty evidence. With regards to dose escalation for partial response, for patients with partial or secondary loss of response to standard 8-weekly anti-integrin or anti-IL-12/23 inhibitors, the guidelines suggest dose escalation by shortening the dosing interval to every 4 weeks. This is a good practice statement due to paucity of available evidence in this day and age. There's a dedicated section on the management of complex perianal fistula in Crohn's disease in these guidelines. The strong recommendation here is for combination therapy, which is basically ceton placement, antibiotics, and anti-TNF agents over standard of care or alternative treatments. And here we're basically endorsing an MDT approach. With regards to the choice of medical therapy, conditional recommendation for using a combination of immunomodulators and anti-TNF over anti-TNF monotherapy for complex perianal fistula healing. What about alternative biologics? There's conditional recommendation for using anti-IL-12/23, anti-IL-23, anti-integrin, or JAK inhibitors, only upadacitinib, obviously, over no treatment for complex perianal fistula healing. Now, compared to the previous guidelines, here we address the issue of biosimilars and switching formulations. So there is a strong recommendation for use of cost-effective biosimilars in Crohn's disease management. For the maintenance of remission in stable, moderate, severe Crohn's disease patients, the guideline strongly recommends treatment with either subcutaneous or IV formulation of infliximab or vedolizumab over no treatment with moderate certainty evidence. We also dedicate a section to post-operative recurrence prevention of Crohn's disease. So to prevent post-operative recurrence of high-risk Crohn's disease patients, the guidelines conditionally recommend using advanced therapy over no treatment. So this is a quick summary for the recommendations made for Crohn's disease management in these two tables. Moving on to ulcerative colitis. So again, strong recommendation for anti-TNF agents over no treatment. For anti-integrins, there is strong recommendation for anti-integrins over no treatment. For anti-IL-12/23 and anti-IL-23, strong recommendation for both over no treatment. And similarly for JAK inhibitors, strong recommendation for JAK inhibitors. Here we have tofacitinib, filgotinib, and upadacitinib, obviously over no treatment. For bio-naive adults with moderate severe UC, the guidelines conditionally recommend using vedolizumab over adalimumab, and this is with moderate certainty evidence. The guidelines also strongly recommend using S1P modulators, both ozanimod and etrasimod over no treatment, and strongly recommend using anti-TNF or IL-12/23 biosimilars over no treatment. Again, we talk about combination therapy. So for induction and maintenance of remission in adults with moderate severe UC, the guidelines conditionally recommend combining infliximab with azathioprine over infliximab monotherapy. There's also a conditional recommendation for TDM, dose escalation of vedolizumab and ustekinumab, and switching classes. So we conditionally conditionally suggest switching to a different class such as anti-IL-12/23, IL-23 anti-integrin, JAK inhibitor, or S1P modulators, over switching to another anti-TNF in patients with loss of response to anti-TNF therapy, despite adequate serum drug levels and negative anti-drug antibodies. A special addition to these guidelines is a section on management of acute severe ulcerative colitis. So we talk about rescue therapy. There's a strong recommendation for using rescue therapy with infliximab or cyclosporin over no treatment to reduce the short-term risk of colectomy in hospitalized adults with acute severe ulcerative colitis that are refractory to IV corticosteroids. With regards to the infliximab dosing, which is a controversial subject, we conditionally recommend using standard infliximab dosing regimens over intensive infliximab dosing regimens to decrease the short-term risk of colectomy in these patients. Also for JAK inhibitors, there's a conditional recommendation for using JAK inhibitors over no treatment to induce remission in adults with acute severe ulcerative colitis who had an inadequate response or intolerance to at least one therapy, including IV corticosteroid, cyclosporin, or infliximab. Similar to Crohn's disease, we talk about switching. So for maintenance of remission in stable, moderate to severe UC patients on infliximab IV or vedolizumab IV, the guidelines strongly recommend either switching to subcut formulations or continuing on the IV formulation over no treatment. And for adults who are in stable disease, so stable remission on the originator biologic, the guidelines conditionally suggest either switching to a biosimilar version or continuing on the originator version. We also talk about the management of recurrent pouchitis. So in patients with UC who have undergone IPAA and experienced recurrent pouchitis that is antibiotic dependent or refractory, the guidelines conditionally suggest the use of advanced therapies over no treatment. Advanced therapies such as vedolizumab demonstrate higher modified bowel disease activity remission at 34 weeks compared to placebo. and the safety outcomes were comparable between the vedolizumab and placebo groups, hence inclusion into these guidelines. So this is again the summary of the recommendations made for ulcerative colitis. Now, we did add a good practice statement addressing the issue of advanced combination therapy for refractory IBD. So, number one, we have the refractory disease. So the use of combined advanced therapy, so biologics and small molecules, for an example, in adults with IBD should be reserved for patients with severely active disease that is refractory to multiple lines of single advanced therapy where surgery is not an acceptable option. For extraintestinal manifestations, advanced combination therapy may be appropriate for patients with uncontrolled extraintestinal manifestations where targeting multiple mechanistic pathways may be beneficial. And finally, we highly recommend that such patients be managed in highly specialized IBD practices or centers with experience in handling complex cases and monitoring for potential adverse effects of combination therapy. Again, this is a good practice statement, not a recommendation. There's emphasis in these guidelines on the monitoring and evaluation framework, so short-term, intermediate, and long-term targets in alignment with the treat-to-target strategy and recommendations made by the STRIDE-2 guidelines. In the final section of the guidelines, you will find that there's implementation considerations discussed, so discussing multidisciplinary teams, tiered referral systems, cost-effectiveness analyses, and clinical decision support tools that have been produced and validated up to this date. Now, an important question, how are these guidelines any different from other international guidelines? There's actually some very interesting differences that should be noted. So, for example, in the post-anti-TNF sequencing decision, the Saudi guidelines show strong preference for IL-23 over ustekinumab based on data from sequence. AJ, ACG, BSG, and ECHO are less prescriptive and give different options. For subcutaneous infliximab, CTP13, we make a strong recommendation for maintenance due to cost and feasibility considerations. For these other guidelines, there's equivalent alternative, and it is really not highlighted as to what are the steps that should be taken. We have a very strong position on recommending biosimilars due to the cost perspective. For these other guidelines, it's accepted as an equivalent, but you'll find that those guidelines are less directive. For combination of infliximab and thiopurine, we do give conditional recommendation for induction. We're cautious about maintenance, and de-escalation guidance is provided. In these other guidelines, you'll find that they're very supportive for induction, but less so on de-escalation. Adalimumab and thiopurine, we discourage routine use and make some suggestions in the guidelines on how to select the patients that are ideal for this combination. In these guidelines, international guidelines, it's conditional by subgroup and less negative. For UPA, we give a strong recommendation with safety caution. International guidelines give a conditional recommendation with individualized risk-benefit. For TDM, we have operationalized reactive TDM with local feasibility. In international guidelines, it's endorsed, but there's less pragmatic detail on what to do. For vedolizumab and ustekinumab, we give very clear and strong recommendations. It is recommended by international guidelines, but often you'll find that these recommendations are conditional. There's many more differences, as you can see, with regarding to acute severe ulcerative colitis. We do clearly talk about accelerated infliximab induction versus standard dosing, and we do strongly talk about early introduction of JAK inhibitors as rescue therapy and how they can be used. With international guidelines, it's more conservative and awaiting more data. For IL-23 and advanced therapies, we give a strong post-anti-TNF recommendation. It is an option given by international guidelines, but usually conditional. For UPA, very similar. For subcutaneous infliximab, We've clearly favored this due to cost and practicality arguments. For international guidelines, it's equivalent, but not given any advantage. And again, same thing for biosimilars. With regards finally to the T2Target strategy, you'll find in this document detailed operational targets mentioned. However, in international guidelines, it's less structured. However, these guidelines do have some limitations. Evidence primarily is given or taken from
1 minute,
global, it's my last slide, global Western studies with non-Saudi or Middle Eastern patients included in the studies provided. There's limited detailed analysis of resource application and cost effectiveness within the Saudi healthcare system, may not fully address the variability in healthcare delivery systems across different regions of Saudi Arabia, and there's limited specific recommendation for special populations. We have lots of future directions we hope to achieve, so establish a systemic updated system with comprehensive reviews every 3 to 5 years, develop a national IBD registry capturing treatment effectiveness and safety profiles in a real-world evidence manner. We'd like to incorporate biomarker validation for personalized approaches, conduct Saudi-specific cost-effectiveness analysis, develop post-marketing surveillance for advanced therapies in the kingdom, and finally, enhance international collaboration to address barriers to guidelines adherence. And this is my conclusions. These guidelines represent an advancement in standardizing care for moderate to severe IBD in Saudi Arabia through rigorous grade methodology. They provide comprehensive guidance for biologic and small molecule therapies in both Crohn's disease and UC, addressing various clinical scenarios from bio-naive patients to those with complex refractory cases. You'll find 38 evidence-based recommendations and 2 good practice statements mentioned. There's a lot of implementation strategy also outlined and plans for future development. I thank you very much for your attention. Happy to take any questions.
Excellent, Professor Mahmoud. Excellent talk. We'll leave the question at the end.
Thank you.
I would like to thank the organizing committee for allowing us for this wonderful meeting, which we wait every year to attend. Our next talk is Professor Vipul Jerath. Without further ado, I would like him to come. He's very well known, and we introduced him yesterday from Western Ontario, and he is a lot of research, and he is the head of fellowship program, and there is a lot of IBD work done under his care. He will talk to us that do we need the guidelines, do we need doctors, artificial intelligence in IBD, where we are heading.
Great, thank you very much again for the kind invitation to be here and to give this talk. See if the clicker works. Okay, so the title I was given was Artificial Intelligence and IBD, and I think this is a beast of a topic. It's not an area I'm an expert in. I'm not sure anyone is an expert in this because it's such a rapidly evolving field. So I'm just going to give you kind of my view of the world as it relates to IBD right now. So if you're into this stuff and you're a computer nerd and you're a technology nerd, which is probably what all our children should be doing today, not what we do, there's lots of different terminologies around this, whether it's deep learning, neural networks, machine learning, it all comes under the umbrella of AI, and there's lots of definitions out there. I think what people think AI looks like is you get some data, you put it into a machine, and you get something out of it, and I think, you know, at a rudimentary level, I think that's what you do get. But what AI actually in healthcare looks like is very, very complicated. There's very detailed data collection at the bottom from appropriate sources, data integrity, data privacy. You need very complex engineering in terms of the AI development, and all the steps are listed out there. And this is where your software engineers come into place. And there's model development, and there's development, and there's validation, there's reiteration, and setting up multiple data sources. This is an iterative process which takes years. And then actually to get something through regulatory approval is a whole another step. This is why you know, AI products really come from academic and industry collaborations. I can't think of any examples where an academic has developed and got a product approved. So these are where, you know, obviously some of the developments come in universities, but for someone to actually make products, it's a huge ball game. It requires huge investments. And then eventually they have to have clinical deployment in trials. So that process there can take a decade. So what about an IBD? I think the allure is big data sets. There's data everywhere. And this is just a list of some of these data sources. These are large biobanks and biorepositories that exist that things have been prospectively developed. And on the right-hand side, you also have data from patient platforms. If you go online, there's all sorts of patient platforms that talk about the way their symptomatology is and how they suffer with IBD. But in the end, it's the analogy at the left that rubbish in is rubbish out. The same when you do a meta-analysis, network meta-analysis. If the data going in is rubbish, what comes out is rubbish. And the same applies here. So there has to be very important ways of data storaging, processing, and orchestration. This is a very rigorous process to have something that's actually useful. Just a few areas where I think big data like this can be useful in IBD. So one of the areas I've been involved in now for 8 years is trying to develop a new patient-reported outcome measure for IBD, which is in front of the EMA now. Again, these are long processes. But this was an interesting study called web scraping, where you can actually go into online forums through AI and big data analysis and really just extract internet posting forums, what patients talk about in terms of symptomatology. So the goal here was, can you develop a PRO from patient platforms? Labeling was done from 20 patients randomly signed, 50 messages, and the goal was to try and identify the PROs associated with a clinical flare. So could you identify those patients earlier on? And then, annotated vocabulary analysis. And it's actually quite interesting what came out. This was flare-associated PROs, impacts on life, impacts on EIMs, symptoms, environment, drugs, and this all makes a lot of sense. Patients get fatigued, they're stressed, they lose weight, have joint problems and other EIMs and major symptomatology. So pretty interesting. We've gone through this another way, spending years and years trying to develop something, and you do something like this and probably come out with similar meaningful things. What else can you do with these big data sources? And you see these, you go to Echo, people put these up, and you see these, we're going to have all these data sets and find how one patient predicts response to one drug and so on. And if it was that easy, someone would have done it by now, right? So in the end, yes, we have all these data sources. The problem is they're not done prospectively in a rigorous manner, linked to outcome data and so on. And that's why some of the registries that you see and biobanks really have provided limited outputs. So what about predicting response to drugs? I mean, this was the Urtralizumab program, huge IBD program. The drug failed, but with advanced machine learning techniques, they did advanced clinical prediction modeling. So that's beyond usual statistical modeling. And they found that, if you had high CRP, MADCAM level, stool frequency, your white cell fecal count, age, much more likely to predict response to treatment. Now, we typically wouldn't put those things in standard prediction model, so it's kind of unsupervised learning, and we'll tell you who might respond. Now, what about harm? I kind of feel like if we use these techniques, we would have picked up harms for JAK inhibitors much earlier on. So remember, when you do a clinical trial, you get an average treatment effect. But at the end, there are people who do not respond to a therapy, and those who are hyper-responders. And the same is true of harms as well. Some people are more likely to get harms to treatment and less likely. And there have been lots of publications in the literature from other disease areas, cardiology mainly, where they take these sort of 10, 15,000 patient data sets and can really tease out which patients benefit and which patients have harm to a therapy. And I think we've got to do better with that. Our trials aren't quite big enough, but we are getting to sort of 1,000 patient clinical trials now. This has got a lot of interest, wearables. We all have a wearable. Many people in the room will have a wearable without even knowing it. You're holding your iPhone. You might actually be wearing a watch or a ring or something. This stuff is constantly collecting data on you. And this is work from Rob Hurton and Mount Sinai, who's done a lot of stuff around wearables and just systematic evaluation of patients, their sweat, their heart rate, the number of hours they sleep. A lot of this stuff is thought to predict flares. So the holy grail would be there's a dashboard monitoring this somewhere and tell you whether someone's going to flare or not. This is probably the area that people are most interested in, AI in endoscopy and imaging. So this was work done by a company called Dover Vision in collaboration with Oxford University, and they did some work in Barrett's esophagus, automated classification of the prior classification for Barrett's esophagus, which you'll be very familiar with. This is kind of what it looks like. It's an AI-assisted evaluation of Barrett's neoplasia. Oh, sorry, I'll just do that. Can we play that? Possible to play that? Does it play? Yeah, it might play here. Let's see. So this is a detection segmentation of Barrett's cancer in white light and narrowband. And you can kind of see the map on the left where abnormal areas, of course, map appropriately. And so it fixates on this area. So the model continues like this. I think it's a long video, we'll move on. But essentially, what it does here is it looks for blind spots, it does automated prior classification, detects spots of neoplasia and depth of the lesion involvement as well, which you can't do traditionally, and then spits out this automated EMR report at the same time. So this has been a product now developed for detection of Barrett's neoplasia, or AI-assisted neoplasia. So really what we do today when we look at video images, you know, we all do this day in, day out. We scope, there's pathology, capsule, MR, CT, ultrasound, and it's humans looking at this stuff. And I think where we will be with this is AI-assisted outputs of this, so rapid throughput, detecting abnormal areas, really AI-assisted scoring, helping you score more accurately, looking at things you haven't missed, like the polyp detection tools that you'll be familiar with, reducing bias, reducing fatigue and variation. One of the big problems we have with the Mayo score is we know if a patient gets a treatment, if they've got pancreatitis Mayo 3, they go into a clinical trial, patient feels fantastic, they're in remission, they've got one ulcer in the rectum, one ulcer, that patient's treatment failure. So when everybody says the drugs don't work, you have 50% endoscopic remission rates, just think about that for a moment. You could be completely normal, one ulcer, and have a Mayo 3. So we don't measure volume of distribution, volume of improvement. So this is, I think, some of the best work in this field. I think, unbiased, Brian Stidham has done this really interesting work where the computer-assisted scoring of the Mayo endoscopy score. So all this does is it takes a video and it continuously measures the Mayo endoscopy score from every point to start to the end. And then it measures the cumulative surface area, the cumulative disease score, and you come out with a score. This was your total Mayo score at the start everywhere. If you sum every segment, average it, and this is what you get at the end. So you see a score before and after. He's published his work in gastroenterology, and he's also published interesting work that if you use a continuous measure like this, you can probably use smaller sample sizes in clinical trials. This is a commercial company in Vancouver called Dover Health. These slides come from Mike Byrne, who's their Chief Medical Officer and founder, and they've done something very similar using the UCEIS score. So this is years and years of process where they label videos, central readers will label the videos, label thousands, tens of thousands of points. They put them through the models, they train the models that come out. And what they've really come out with is a scoring of the UCEIS score now. And you could just play this as well if you like. But typically, it will go through. You look at the 5 components of UCIS there. It will measure everywhere. You see these things throughout the scale and then come out with a score, but also come out with a cumulative disease burden as well. Remember, the machine sees things a human doesn't see, so it's probably going to score always worse than human scores. I think it will overscore and more conservatively. So, these are repeatable. You get deep mapping, you look at total burden of disease. So it also gives you new information and new scoring methods that humans can't read. There's billions of publications out there. This is another work, looking at virtual chromoendoscopy. I mean, there's an academic publication every week, and this is all great, but unless these things turn into products, and products that can be implemented into clinical care, they're really just of academic interest in my view. So MR is really important. We all do MRE and CTEs, and same thing here is done. This is a very nice paper, again, looking at automated bowel wall thickness measurements of strictures as well. And so this AI-assisted measurement of bowel wall thickness and proximal small bowel dilation. There's some nice work looking at AI assessment of small bowel strictures and fibrosis in Crohn's disease, and again, you get better inter-observer agreement than humans as well. So, ultimately where we might get, you take all of these things, we enhance these methods with assisted AI techniques, and there's many initiatives ongoing around this, and this can ideally be used in clinical practice, but I think also within clinical trials as well. Now, what we really need is and some of you might be doing this already and where you practice, depending on what is automated reporting. And this applies to all areas of healthcare, not just IBD. So, chatbots are there. If you go and try and search for a new car and the chatbot pops up and it gives you 25 questions and eventually it can't answer what you want and then you have to ring up the next day. But it kind of gets you interested. So there's all sorts of work about chatbots versus humans and answering patients' questions. And this comes from social media forums. And actually the chatbot does pretty well in terms of quality and empathy ratings as well. Apparently is empathetic as a human as well. But this is, these are some interesting things. Can you write a report analysing this chest X-ray? Chest X-ray is a little bit easier to put through an AI tool. It's not so three-dimensional and dynamic and moving, and it goes in and it gives you an automated EMR report and tells you there's no disease. Many of you be using automated who uses automated transcription notes now? Or do you still type? Or, yeah, so I think many of us are using tools. They've been around for years. But this really speeds up our clinical practice. And of course, there's lots of tools now where you just have the recording on, and it'll generate an EMR report for you in a PDF straight into the EMR. And I think increasingly we're using this stuff. So like this, it's on during the consultation. It creates a PDF that goes straight into the electronic medical record, and I've started to use this as well. And really, this is what we're trying to do, natural language processing directly from the EMR. So you can take all those things, automated documentation, and these are also very useful as well for when you're trying to do research studies as well, because you could easily identify patients with IBD, with UC, with proctitis, run reports like that, and end up with a very clear repository of things. So I'll quickly whiz through my area of interest is how we use AI in clinical trials as well. Trials have got very, very complicated. So if you look over the last 20 years, we collect more and more endpoints, we do more and more procedures, more and more useless data that we collect in clinical trials. No one ever does anything with it. But with AI, we potentially have the use to use that in a much more rigorous way. So we can use AI anywhere, designing trials, recruitment, follow-up, analysis, interpretation. We can use AI to match patients to trials. So this is a clinical trial of, this is a 58-year-old African-American woman comes to the ER with chest pain, and you have something called Trial GPT, which is a bit like Trap GPT, and this can match the patient to a whole host of clinical trials that are potentially out there. This is in Nature Communications. Some of you may have always-on capture devices in your endoscope rooms that continuously record everything. And I think this is excellent for identifying subtypes of IBD when you're looking for clinical trials. You might need patients with ostomies or perianal disease or pouches, and having that repository of videos I think is important. Screen failure, the biggest reason that you don't get into a clinical trial is because you don't have enough disease activity. Your Mayo score is too low, SCSCD score too low. So I think having AI assistance in the room will immediately tell you what that score is in a rigorous manner, and it will reduce screen failure rates in clinical trials. This is quite interesting, using intestinal ultrasound to do bedside ultrasound to see if people have got inflammation or not, as a methodology of reducing screen failure. Informed consent, for those of you who recruit to trials, we give patients this 25-page thing which is incomprehensible. I mean, it's not fair to a patient who may have no medical background that you give them this informed consent because ethics committees think it's ethical. And frankly, they can't understand most of what's in it, and that's what the research shows. And it's all medical legal stuff. Sure, we have to provide it, but it's our duty to provide it in a way that people can understand. And there's increasing work out there where you can have automated videos or chatbots that can explain things to patients in the way that they can understand it, to their level they want to understand, and they can do it in the evenings and the weekends and at night time, at time that's convenient to them, and there's examples of that as well. Talked about AI-assisted endoscopic image interpretation as well, which is going to be coming to clinical trials very soon. This was interesting, stool analysis, right? So this was somebody who developed an app, took pictures of patients' stool with IBD and told you what their Mayo score was and whether they're in remission or not. That's also quite interesting. Patients in big countries where they live in rural areas, we're trying to determine whether their symptoms and they have a flare or not. There's something pretty cool, I think, that could be implemented into disease monitoring. How is this all going to be used? It's hard to say. Recently, a company called Path AI in the US who got a device approval for MASLD. So they've taken clinical trial. They did a very rigorous process of many years. They took biopsies from livers in MASLD trials, and now have this device approved. So now a human does not, we think, a human does not have to read these. However, what the regulator very clearly said is that these tools cannot be used to replace a human. They'll be used as supplement to a pathologist. So the machine will read the biopsy, and then the human will have to say whether it's right or wrong. We talked about wearables. And then the other big area of clinical trials is decentralized monitoring. We have to monitor for safety. We go to sites and monitor. And AI can be used to look at sites who are over-recruiting, under-recruiting, data integrity might be poor, and focus in on there. So really, I think both in clinical trials and clinical practice, we can use it in matching patients, finding them, assessing disease activity, image analysis, safety monitoring, and also reporting of the results. So I'll stop there. Happy to take questions. Thank you.
Excellent, Prof. Have a seat.
Okay, it's my pleasure now to introduce the next speakers. Dr. Mohammed Shahab, an eminent gastroenterologist from Kuwait. He's the General Secretary of Kuwait Gastroenterology Association and an IBD specialist. And Dr. Thamer bin Turki, Associate Professor of Surgery and Head of General Surgery Division at King Saud University Medical City, Riyadh. We'll have an interesting talk now about the gastroenterologist's take and a surgical take on perianal Crohn's disease.
Good morning, everyone. Thank you, SGA, for inviting me. Always happy to be in Riyadh. Today, I'm going to talk about the medical management of perianal Crohn's disease, one of the difficult areas in IBD and maybe represented in clinical trials, and will be a tandem talk. Dr. Thamer will join me to talk about the surgical management, and the audience will decide what's the best treatment, medical or surgical treatment for Crohn's disease, for fistulizing Crohn's or perianal Crohn's. So this is my outline disclosure. So we know fistulizing Crohn's is a very difficult subtype of Crohn's disease. We think from this data we have, maybe 35% of patients, this is Western data, they may have fistulizing disease of all patients with Crohn's disease. We always need collaboration between surgeons and gastroenterologists to treat those patients with fistulizing or perianal Crohn's disease. Most of you know this maybe figure very well. We know the prevalence of IBD is increasing, especially in our areas, due to many factors. We think industrialization, westernization of our diet, maybe processed food, and others. So we have more patients with IBD and more patients with Crohn's disease. We didn't have, or we don't have as robust data as the West in our region, but recently now we have, I'm going to show you next, that we have this data we've been collecting over the last 3 years or more, now we have 10,000, as we speak now, more than 10,000 patients involved, more than 12 centers across 7 countries in the Middle East, patients with IBD, UC, and Crohn's. So this is, if you can see, it's very interesting now, this picture, this figure. I just added Emirates maybe last week, so you don't see it in the figure, but you can see the prevalence of Crohn's disease, maybe the highest. Saudi Arabia was maybe the first in the race, but now Emirates is higher than Saudi Arabia in terms of Crohn's disease. And then on the left, if you look at the perianal Crohn's, it's also higher in those red countries. So Emirates followed by Saudi Arabia, followed by Kuwait, we have the highest prevalence of Crohn's versus UC. And then you see the perianal also, we have the highest. So maybe it's it's very interesting, I don't know, the country, cancer, we start with UC, and then the country becomes more CD than UC, and then you have more perianal disease. And this is, I think, other countries will follow. Same with westernization, with diet, we have more perianal disease in other countries. If we talk about classifying fistulizing Crohn's, so we know Crohn's, 2/3 are usually external and 1/3 are internal. Fistulas, external usually the perianal and enterocutaneous fistulas, internal usually the enteroenteric, rectovaginal, intravesical, interabdominal fistulas, but the most common that is perianal fistulas, and this is the commonest we see in clinical practice. And this was one of the difficult, like as we mentioned before, difficult entity to treat in patients with IBD. Other ones are less common, like enteric are less common, maybe 24%, rectovaginal, other are less common than the perianal disease. And the lifelong time risk of developing fistula is around 20 to 40% of patients with Crohn's disease. Then we go to classification. So we are familiar with the PARC classification, which is like more anatomical classification when you have the superficial fistula, which does not cross the sphincter. Then we have the intersphincteric fistula, which is cross between the internal and external sphincter. Then we have the transsphincteric fistula, which goes above both the sphincters, and then we have the suprasphincteric fistula, which goes to the levator ani and goes outside, and then the advanced 5, the extrasphincteric fistula, which passes and goes to the rectum. Another classification, or the AGA classification, you can see that the simple and complex fistula. Simple, usually the patient who had low superficial or low intersphincteric or transsphincteric fistula, and there is single external opening and no abscesses or no rectovaginal fistulas or anorectal structure. Whereas we call it complex fistula when we have high intersphincteric or high transsphincteric fistula, multiple external opening, we have abscesses or fistulas. This is more of a complex fistula, we describe it. And then recently, you heard about the top class classification, where the other classification, more like anatomical classification, this is more dynamic classification. With class 1 was like minimal disease, the patient have symptoms, require minimal intervention, and those patients can go to the class 2, where is chronic symptomatic fistula, and those patients can be amenable to repair with medical plus surgical therapy, which is class 2A, they call it, or if they're not amenable to repair, then it's only treat for symptom control, which is class 2B. And those patients may need further treatment, which is diverting osteostomy, and then they class 2C. And those patients also can be subdivided into 2 classes, whereas early rapidly progressing with those patients can progress very rapidly within weeks, or those patients who gradually developing disease will make progress slowly over 3 to 6 months. And then both classes can be like dynamically go back or go to needed proctectomy. And then if they need proctectomy, that's class 3. And after proctectomy, some patients, unfortunately, may develop also symptoms and complications. And they also subdivided these classes to those patients who can be repaired medically or surgically, or those patients who maybe only needed symptom control. Again, it's more like a dynamic classification. It's a bit complicated, but this is this is how we classify perianal disease. So diagnostic modality. So we know we send patients for EUA by the surgeon for examination under anesthesia. It's a gold standard, very helpful to examine for perianal disease. MRI or MRI of the pelvis is now widely used, and it's recommended to look at the anatomy of the perianal disease. The fistulography and maybe CT scan is now out of favor. It's not recommended by echo because it doesn't tell you the exact anatomy of the perianum and the pelvis. So MRI is a better modality of choice. AUS can be used if you want to look at the internal sphincter evaluation. And transperineal ultrasound also has been used in some centers. It's also useful. However, the transperineal ultrasound cannot, if you have deep abscesses, cannot be detected by transperineal ultrasound. We always do endoscopy, mainly to look at the inflammation, the proctitis, and inflammation of the colon. And also maybe we can see internal opening and endoscopy. So combining EUA plus MRI, this will give us the best accuracy of diagnosing perianal disease. So now moving to the medical management. So start with the older management. So the antibiotics first. The antibiotics, the common ones, what's been studied is metronidazole and ciprofloxacin. They usually to manage symptoms of perianal disease and septic complication. We know they are not curative. Most studies, they will be given to 6 to 8 weeks for induction of remission, but you don't keep them for maintenance of remission. They have side effects and they have some toxicity, so we don't recommend it, and they don't work for maintenance of remission. So they have many randomized control trials, the older ones that compared them for induction of remission. Maybe Cipro in one trial was better than metronidazole for remission. And also we know like infliximab plus Cipro in one trial that's better than Cipro alone, and also adalimumab plus Cipro is better than adalimumab alone in these older trials. So moving to immunomodulators, I put azathioprine, 6-MMP, and maybe tacrolimus as well. So these like 6-MP and azathioprine were assessed fistula response as a secondary endpoint in 5 randomized controlled trial. 54% responded. There are only 21 in the placebo group, so there was a response here. But immunomodulator, they said, were better used in cognition with biologics, not alone. Tacrolimus, however, there were small studies, like 48 patients in one study with perianal disease. Symptom improvement was seen in maybe 43% versus 8 in placebo, but fistula remission was not significantly better the treatment group versus placebo in this small trial. So moving to anti-TNF, which is now, we know, the first-line therapy. So the older the response rate of 62% in the accident, the closure rate also in the accident study was 36% versus 19% in the placebo group. And up to 46% had complete remission, as you can see the figures on the right up to until like 54 weeks. Combining them combining anti-TNF with antibiotic and cetones were also improved outcome. But however, in those studies, we know 30% had loss of response, which is expected with infliximab due to immunogenicity. How about adalimumab? So adalimumab was effective in the CHOICE trial in patient in infliximab non-responder. So we can try it if you failed infliximab, dealing with the immunomodulator. And in CHARM, you can see on the right in CHARM, so versus placebo versus adalimumab, we do the adalimumab did better than placebo in the fistulizing in perianal Crohn's. And also you can see them up to 56, there was a difference between placebo and adalimumab. And also in the ADHERE, which is a long-term extension, was also showed efficacy of adalimumab versus placebo. However, in the classic 1 and GAIN studies, there was no significant difference between the treatment arm and placebo. Moving to certolizumab, there was variable efficacy. There was 2 small studies. The first one was negative, like 31% patient had their clinical remission versus 30 in the placebo. The second one, there was a better response with 54% versus 53 in the closure and certolizumab versus placebo, but those were small studies, so they're very valuable benefit. Maybe you can use it as an alternative option. So how about non-like anti-TNF biologics? So ustekinumab, we know it targets IL-12 and 33, so certify Unity 1, Unity 2, there was no difference between them and versus placebo. In SAVEU and Stardust, there was some positive result. In SAVEU, 53% versus and 37%, 0.5. Patient adalimumab both had achieved complete fistula closure after 1 year. When they looked at the trough levels, like trough level ustekinumab and adalimumab did not was significant between them and between the placebo. There was no association between trough level. However, here there was small sample size, so I don't think we can draw a conclusion because we know higher trough level, other studies is better with anti-TNF associated with a better closure. So moving to vedolizumab, which is an anti-integrin. So Enterprise, I may mention maybe yesterday, it's a study like patient with perianal Crohn's disease. We can see like patient who had the standard dose, so 0, 6, 14, and also patient who had like week 10 as well dose. They both had sustained closure, and you can see here like patient had 42% on those who had week 10 and 64% who did not have week 10, and the pooled were 53%. But bear in mind, this was like a single-arm study. However, in Gemini, you can see down, there was like a numeric difference between the baseline in week 14 and week 52 between placebo and vedolizumab, but there was no statistical difference in this study. And the both ustekinumab and vedolizumab didn't do very well at the modus effect if the patient had the refractory cases of perianal disease, failed like more than 1 biologics. And then, so the question is now which one to choose. So we don't have like a head-to-head for perianal. We don't have like a perianal per se one, like dedicated studies, big studies. So we don't have head-to-head. We did like a network meta-analysis a few years ago to look at this of biologics. So infliximab was superior to adalimumab for induction of response, but not for remission. But comparing the biologics to each other, there was no significant difference in induction of remission. But TNF were effective in inducing response and remission in fistulizing Crohn's. So what goes with the clinical practice, infliximab is the first-line therapy, maybe followed by adalimumab. Then how about small molecules? So we know now JAK inhibitor like upadacitinib, alfalgatinib, we know they have oral, like let's maybe have some advantages, oral route, low immunogenicity, and they walk very fast. What data we have? So we have the post-hoc analysis of the phase 3 trial from the UXEED and ENDURE studies. And you can see this is like a post-hoc, maybe around 140 patients, the induction study. And you can see the resolution of drainage and closure of external fistula was both significant in perianal fistulas and any fistulas in the induction of remission. You can see in the maintenance of remission, the closing the external opening, both in any fistulas, perianal fistula was significant, but the resolution of drainage was not significant in the maintenance. But how I think but it's still the small sample size. You can see we don't have enough patient. Maybe we need a bigger study to see if there is a difference. And then we need moving to mesenchymal stem cells, which is now like for those refractory patients, maybe we can do MSCs. So this is indicated for complex perianal fistulas, unresponsive to other medical therapies. The mechanism we think is anti-inflammatory and anti-tissue regenerative disease. So the ADMIRE study first, which there included around 40 patients, showed a difference. 50% had remission versus 34 in the placebo at week 24, and up to 68% remission at 52. However, the recent one, the ADMIRE 2, there was no statistical difference between the two arms. If you can see here in the figure, there was no big difference. The Kaplan-Meier here, there was no difference between the two in the ADMIRE 2 study. However, we have a lot of observational data that showed MSC works and have maybe promising results, autologous and bone marrow derivative cells. How about combined biologics? So this is a recent study published in the UEG journal. So they took patients who had refractory perianal disease, and by refractory, they failed 3 biologics, and then they gave them a prospective study in France. They gave them infliximab plus ustekinumab, and 84% of these patients already received infliximab of this population, and maybe 35% received adalimumab, and 50% of those patients had external manifestation. And you can see assessing clinical remission, which is absence of external opening, around 48% had clinical remission, and complete radiological remission by there is no inflammation in the MRI pelvis, or around 24%. And they also assess patient perception, where the patient feels well, there is no discharge of fistula, around 90%. So it's very patient, maybe called patient-reported outcome was very good in this study. And there was poor prognosis if the patient have primary anal ulcer or long-term antibiotic therapy. So maybe dual combinating therapy is one of the choices for those kind of patients. So surgical management, now I will move, maybe Dr. Thamer will talk about the surgical management.
Good morning, everyone. Thanks for inviting me for this meeting that I'm waiting every year for that. Surgical management in perianal Crohn's. First of all, should we treat all? If a patient with minimal symptoms, usually do nothing for them because we cannot expect the outcome for such patients. But if the patient is symptomatic, how to choose our surgical intervention? Is it a temporary measure or it is a permanent? What do you mean by that? A patient with rectal involvement, patient with a other perianal disease like stenosis, fissure, skin tags, or other GI disease like involvement of the terminal ileum, involvement of colon stricturing. Based on each one we decide. So in a patient with rectal involvement, for sure no definitive measure for them. In a patient with associated anal disease like anal stricture, again, we are not doing a definitive measure. Always we are waiting to assess the medical management control of the patient disease. If the patient is symptomatic and we are going to go with a combined disease, we are going to go for seton. Most of the time our setons is going to be a draining seton, not a cutting seton. So Draining seton, when should we remove it? Less than 3 weeks, 100% failure. More than 34 weeks, high risk of failure. So when it was first combining draining seton and infliximab, first paper was published around 2008, they found we removed the draining seton after the 3rd dose of infliximab. But later on they found if we remove it after the 5th dose, it's going to be a better outcome. But sometimes we cannot remove it, we have to keep it for a longer period of time. Again, removing the draining seton before 3 weeks, 100% failure. Removing draining seton more than 34 weeks, again it's a failure. But again, this depends on a patient condition. If a perianal disease is active, discharging, not dry, we have to keep the drain, the seton. So what about if there is no rectal involvement, no GI disease, no other anal condition? We can go for the second step, lift, stylotomy, plug, fibrin glue, or even the mesenchymal injection again. So these depend on which type, which muscle involved. Is it only simple fistula, or transsphincteric, or suprasphincteric, or extrasphincteric? Again, for a complex fistula, combined surgical and medical management as per ECO guideline is the standard. Diverting stoma and proctectomy, we don't like to do them if in a combined anal disease, because the stool usually is a self-dilator of the anus. So diverting the patient, if they are not going to respond to medical management, this means a permanent stoma. So we are always hesitant to give a patient a stoma unless we need, because we need the stool as a self-dilator. Thank you.
So continuing now with the medical therapy. So one important thing is the quality of life impact. We know patients with fistulizing Crohn's, they suffer a lot. Many of patients, they have inability to go to work, ability to go to school. They have problem with the marriage and the sexual life, and they have they cannot go to any social meetings. So it's very important to address the quality of life of those patients with perianal disease. And there is a validated tool. You can use the Perianal Disease Activity Index, Crohn Anal Fistula Quality of Life Scale, which can help you also to identify those who have quality of life affected. So what is we think coming for perianal disease? So maybe trials exploring autologous or allogeneic MSCs. This may be these are helpful in patients with refractory perianal disease. Combining surgical and maybe combo now advanced therapy, maybe this is also the way to go in patients with refractory perianal disease. A personalized medicine, maybe this is biomarker. Ideally, if we have biomarkers that tell us this patient have aggressive or have perianal disease, and we can guide it by biomarker or imaging, that also will be helpful in those patients. So what we propose as a recommendation, so we starting with first with anti-TNF, preferably with infliximab. Get the surgeon involved to evaluate for the fistula if need to put a acetone or not. And then if you're on infliximab, and you can induce with antibiotic therapy as well. And then you get your trough level of infliximab high. So aim for high trough levels, because I've seen some physicians with just normal 5 or 10 trough level, and then they gave up and they switched to another medication. So I aim usually for trough levels above 20 in patients with infliximab. So aim for higher trough levels and to get the patient into remission and close this fistula. If you fail the infliximab, and this depends if it's mechanistic failure or immunogenic, if you have immune reaction, immunogenicity, you can switch to adalimumab with immunomodulator. If you're mechanistic, then you can switch to another biologic. So after anti-TNF, what is the best advanced therapy? That's a million general question. We don't have an answer. What's the best after anti-TNF? You can use ustekinumab, you can use vedolizumab, you can use, but we have with the post-hoc maybe for the opacitinib, so you can use any of those. If the patient failed therapy, then you get the surgeon involved, may need the surgical treatment or may need also MSC treatment. To conclude, the patient with fistulizing Crohn's is complex and debilitating. We need interventions, complex with medical, surgical, and other specialties. We need the precision medicine, and maybe biomarkers will help us in treating those patients. Unfortunately, we know like your clinical trials, not many, like most of them don't involve perianal disease. Now we have more trials that involving perianal disease. I think the gozulcanimab also have a trial that's involving perianal disease, because we have lots of UC, and we have maybe 35% of our patients have perianal disease and not represented well in clinical trials. So we need more RCTs to involve those patients. Thank you.
Excellent, Shihab. Thank you. Have a seat. Our last talk today is by Dr. Bashar Al-Ibrahim. He is a consultant gastroenterologist specialized in inflammatory bowel disease in King Fahd Medical City in Riyadh. He earned his MBBS in King Saud University 2007, and he did the Saudi board in 2014. Dr. Al-Ibrahim is trained extensively in Canada, did his fellowship in GI and IBD in McMaster University and the University of Western Ontario, as well as IBD ultrasound fellowship in 2019. He hosts the Canadian and American board certificate in internal medicine and gastroenterology. He's an active researcher and award winner presenter. He authored multiple publications in high-impact journalists. Dr. Ibrahim is a member of several international gastroenterology association and advisory board. Welcome, Bashar. He is going to tell us about biosimilar latest update. The floor is yours.
Thank you, Dr. Hamad, for this nice introduction. It's a great pleasure to be with you this morning. And let me start my presentation with a practical question. How many of you still have infliximab originator in their pharmacy?
Nobody. Well,
Makawi.
Okay, so a good number. I'm asking this question because in my own hospital, it disappeared as of 1 year ago. So we only have biosimilar. So the originator is not a choice anymore. So today we'll talk about understanding the concept of biosimilar and how they differ from originator biologic. We're going to review the evidence for biosimilar in IBD and Crohn's and ulcerative colitis. We're going to discuss the key efficacy and immunogenicity data, and we're going to explore some real-world consideration regarding switching and cost-effectiveness. The FDA and the AGA define biosimilar as highly similar but not identical to the reference biologic, with only minor differences in clinically inactive components. And I want to make this clear. Biosimilar is not similar to generic medication in many ways. So the biologic agent are a complex large molecule which manufactured by each manufacturer uses a unique cell line. So it's not easily replicable, similar to the small molecule or generic medication. And it is sensitive to the storage and handling condition. And the reaction may be attributed to both product and host-related factor. Whereas the small molecule is usually, the reaction is intrinsic and is not easily attributed to a specific product. The FDA requirement for approval of biosimilar, no clinically meaningful difference between biological product and the reference in terms of safety, purity, and potency. I want also to make it clear that even in originator, there is a well-known phenomenon called lot-to-lot variation. So the originator that I use in my hospital is not similar to the originator somebody else using, because each one is produced by cell line. So even from the same manufacturer, there are some minor differences. Mostly these are not clinically significant. Why biosimilar matter? For many reasons. Unfortunately, I don't have most of cost-effectiveness data from Saudi, but from US, biologic account only for 2% of the prescription, but more than 40% of the net drug spending. about $120 billion of healthcare, and about 90% of overall growth in the total spending since 2014. And it's estimated that since the introduction of biosimilar, about $36 billion of saving in healthcare cost. This price competition is actually matter for our patient because it increases the product availability, to permit the use of this therapy early in the treatment, increase the patient access, decrease the premiums of healthcare cost, and encourage development of new medication. As we saw in the past few years, we have many of a new medication hitting the market because of many of the originator going biosimilar. What are the key terms associated with prescribing biosimilars? So there is transition or switching, which is led by the physician, and there is interchangeability, which meaning that the same clinical result can be expected from biosimilar compared to the originator. And there is automatic substitution, which we had actually in our hospital. So the pharmacy change to interchangeably changing between biosimilar in place of the reference product without the direction of the physician. So that as of 2024, the FDA issued this statement that switching study between reference and biosimilar consistently show no meaningful differences in key outcome of effectiveness, safety, or pharmacokinetic. And the current analytic technology can be characterized the biologic, protein, and module function effect with high degrees of sensitivity and specificity using in vitro assay, meaning that you don't necessarily need a placebo-controlled trial to approve a new biosimilar anymore. It can be assisted in vitro. Many biosimilars available around the world, mostly for adalimumab, different forms, infliximab, and newly now ustekinumab. And the beginning was back in 2017, started the study, in the North Switch study. It's a 52-week prospective randomized double-blinded non-inferiority trial across infliximab indication, GI and dermatological. And the patient was randomly switched to originator infliximab or biosimilar CTB13. Endpoint was disease worsening in any indication, and non-inferiority margin was met in terms of loss of response, safety, and immunogenicity. A lot of criticism when this first came. A lot of us were skeptical about it because of the high non-inferiority margin of reaching the 15% in Crohn's disease. The endpoint was purely clinical, not based on endoscopic. And as I will show in later study, this non-inferiority margin turned to be less in other studies. This study actually is a nice study where they randomized the patient to receive either CTB13 induction or originator induction, and then again switch to either maintenance with the originator or biosimilar. And this one has also some endoscopic data, as you can see in the left lower table. So no much difference between the two in terms of mucosal healing, in terms of clinical efficacy. This was also shown again in several other studies showing non-inferiority of switching with unchanged disease activity, CRB, endoscopic activity, and long-term remission. Large database also shows similar efficacy and safety to biooriginator. No difference in drug clearance, with some exception, and that I will talk about later. So stable drug levels, no increase in anti-drug antibodies. This is again nice study from Hungary, where the patient initially was on biosimilar, then switched back because there were a shortage of supply on biosimilar, and they switched back to the originator. And even when they switch back, there is no much difference in the level or on clinical efficacy. So this supports the interchangeability use. But where does it came? Like I'm probably many of us heard about it, especially in the early day of biosimilar. A lot of experts thought that maybe they are less effective. And my explanation to this, I think, there is some conflicting data regarding the drug level. So this is a nice study from Spain that looked at the trough level during the induction with either originator or CTB13. And as you can see, there is some statistically and clinically significant difference during the induction period. Also, the left figure showed the trough level data from the NOR switch. And you can see some difference in the trough level, especially in the beginning, in the induction. So my take from this, maybe there is some minor difference especially in the induction period, in the pharmacokinetic. What does that tell me in my practice? That probably patient who's not responding well, I need to check the trough level earlier and react upon it. There are some confliction about this, but I think there is some good evidence that the trough level might be different a little bit. What about the local real world data? And this is data from Dr. Mosley, actually presented as an abstract during last ECHO. And they study about 156 patients, mixed UC and Crohn's, and reported the clinical efficacy comparable to the originator. I don't have the full publication, but this was presented as an abstract. But what was remarkable is the disease control rate in the switched patient. So the patients who were switched from originator to biosimilar, they have a disease control rate of about 100%. In UC, in Crohn's, and about 93% in fistulizing Crohn's and UC. Dr. Turki talked about this morning about the subcut infliximab, and initially this is basically biosimilar. The originator has never been produced as a subcut form. And the beginning was with Dr. Schreiber's study from Germany, with 2 inductions, IV dose, then randomized to either IV maintenance or subcut. And as shown by Dr. Turki, the trough level were better. With the subcut dose, the clinical remission rate was numerically a little bit higher in subcut, but not statistically significant. And the adverse event profile was quite similar, except for local injection site reaction, which is expected in subcutaneous medications. Again, post hoc analysis from the study compared patients before and after subcut switching. And the median trough level was around 20, as we mentioned earlier, compared to 2.3 in the IV CTB13. This post hoc analysis, and we have to be careful with the post hoc data, but it showed some significant difference in endoscopy score comparing week 24 to week 54. Meaning before and after switching. Median calprotectin also was lower in patient post-switching. And this study did not show much difference in, or actually decreasing anti-drug, antibody and neutralizing antibody between before and after switching. But there are later data showing a little bit different results. And they will show it later. So the Liberty also talked about by Dr. Turki, 2 trials, Crohn's and UC, and actually the FDA, American FDA, mandated this trial because they considered subcut infliximab to be a new medication. So they mandated a placebo-controlled trial, and again, quite similar study design between UC and Crohn's, to the three IV induction dose. Followed by subcut and placebo arm, and it show clear efficacy over placebo with no much of a new safety signal except for, again, for the local injection site reaction. The UC study also, the Crohn's study showed also a durable effect up to 2 years, 120 weeks, when continuing on the subcut infliximab. And the pharmacokinetic again was good. Actually, the trough level here was around 20 again, but the thing that is different than the Dr. Schreiber study, the European study, is actually the anti-drug, anti-liver rate. So they reported about 65% positive antibody. The author attributed that to probably high sensitive test used. When we look at they divided the titer of antibody according to the quartile, and they looked at the trough level compared to the antibody. And it seems that the trough level is a little bit lower in the higher quartile with, of anti-drug antibody, but this does not translate into clinically meaningful loss of response, at least in this study. So the response rate was similar across the, like in positive or negative antibodies. But this also leads us to think maybe in certain conditions like fistulizing disease, this might matter. But at least in their study population did not show much difference. Because actually the trough level is way above what we used to target in IV infliximab. So to optimize switching, still some question need to be answered, and some data from the REM switch presented by Dr. Turki this morning. But this is a recently studied and recently published study from last month actually, showing comparing patients who were on standard dose, who were switched to subcut, compared to the patient on escalated dose, and it looked only at the fecal calprotectin, so no much of endoscopic data, but it seems that the patient on escalated dose on 10 milligram per kilogram Q4 did a little bit worse when they are switched to the standard dose. So this probably suggest, support the higher dose use in patient who's already escalated, but this need also to be looked at in a randomized prospective study to decide exactly which dose you should be switched to. But for now, I think there are some evidence suggesting probably using higher dose when you switch patients who are already escalated in the IV. Many biosimilars for adalimumab, some of them are citrate-free, come in different forms, 10, 20, 40 milligram, used in rheumatology and IBD. And the approval was based on the Voltaire trial in US. So about 147 patients randomly assigned to adalimumab or a biosimilar, similar clinical efficacy and side effect profile. Mean percentage decrease in SE, and the endoscopic score was numerically higher, but not statistically significant in the biosimilar arm. So at least it's not inferior. What about switching from biosimilar to biosimilar? Another single center prospective observation study looked at patients who had multiple switch, and at 6 months about 88% remained on the switch product, meaning no failure of treatment, and also no steroid, no dose escalation, and no discontinuation. But some of you might think probably if you lose about 18 or 20% of your patients who are in stable remission, this is a big number, and this is actually attributed to many factors that we will come to later. So another real-world study compared 4 biosimilar of adalimumab from Italy, and it seems that they are almost equally effective, no much difference, but again showed a lot of patients who were switched while they were in unstable remission, lose their response. So about 19% in this study. So 80%, 81 of switch patients remained on the medication. And no new safety signal. And the author of this paper actually attribute this to the nocebo effect. And we'll come to that later. And I can add something else also. In this study, the escalation rate for adalimumab was quite low. And we know, like most of anti-TNF are level dependent. So, if you have a low running trough level, probably you're going to lose many of these patients anyways if you're not monitoring. So the escalation rate in this study was about 1.5% of the patient only. So not much of the patient escalated, probably this attributed to the high loss rate. Ustekinumab biosimilar, as I mentioned, the FDA do not mandate now a specific data in IBD. It can be extrapolated from other indication, and there are not much of real-world data or IBD specific data on ustekinumab biosimilar. So it was approved mainly from extrapolation from data from plaque psoriasis.
Dr. Bashar, 1 minute.
Yeah. So what are the patient prospects about biosimilar? So this is a French study, looked at about 1,300 patients. And about 50% expressed some concern about the biosimilar is less effective than the reference product. And the knowledge gap about biosimilar among clinicians is understanding the regulatory process, prescribing interchangeability and clinical implication, and patient education and data on real-world data. And how to address this knowledge gap or how to do this transition smoothly is actually by providing clinicians with updated information, utilize pharmacists, who's a very valuable resource in choosing biosimilar, and encourage clinicians to consult a creditable scientific literature. Beware of nocebo effect, we mentioned that, so it's defined as unexplained, unfavorable therapeutic effect after non-medical switch from reference product to the biosimilar, with resolution of when the patients switch back to the reference. And in some study, it is reported to be up to 12.8%. So a significant number of patients will have this nocebo effect when you switch them to the biosimilar. So how to overcome this? Also, the ECHO had a statement about switching, and it indicated the significance of collaboration between pharmacist and physician, and IBD nurse actually is a very valuable resource because they are the first healthcare personnel that the patient reach out with their question about biosimilars or medication. And how to approach biosimilar with your patient. So use active ingredient name, not the brand name, because the patient gets emotionally attached to the brand name. And define biosimilar, clarify the reason for biosimilar use, review practical implication. Important resource actually in many languages, the FDA website, including Arabic language. Reassure your patient about safety, effectiveness, no change in treatment target, and same drug assay. And this is the website from the FDA. It comes even in Arabic language, so you can refer your patient for more information. The key learning point from this talk is that there is a robust evidence supporting switching to biosimilar in IBD without loss of efficacy and safety. Integration of biosimilar into clinical practice has yielded significant cost saving. Best practices in switching require clinicians to be knowledgeable about the science behind the clinical evidence and the safety and efficacy. Without patient education and knowledge, a knowledgeable clinician, biosimilar switching may lead to undesirable nocebo effect and poor patient acceptance to biosimilar. Thank you very much.
Excellent. Thank you, Dr. Bashar. Proceed. So we'll open the floor for 10 minutes for discussion. I'm sure there are lots of questions on the floor. Yeah. Can we have a microphone there, please?
Thank you very much for a perfect lectures. I'm Dr. Abdurrahman Kanam. My question to Prof. Mosali. We know most of the guideline in the IBD is treat to the target. And our definition and our understanding in the definition of target is improving the clinical symptom and macroscopical, endoscopical healing and histopathological improvement. And you know, this idea to not reach us to cure, to treat to cure. You know that most of the IBD is not a curable disease. And when we will reach to the level to look for the gene therapy, comparing with our brother in hematology now, they reach to the cure sickle cell disease. As you know, there is gene therapy. So my question, is there any study or any research to involve the gene level as a part of the deep definition of the improvement in a patient with IBD?
Wow. So to my knowledge, there's a lot of studies on molecular healing, and I believe Professor Jerath talked about that a little bit yesterday. The closest we are to this, I think, is, I would say, years and years away. I don't think we're nearly close to reaching molecular healing as a target for IBD or cure. I think the concept of disease clearance, which we talked about yesterday, is probably going to become the ultimate endpoint or goal that we seek in our patients. And we all are very eager to see the results of the Verdict study led by Professor Jerath, hopefully soon.
Yeah, I think I agree, and I think it's hard to know what molecular healing actually is. I mean, is it peripheral blood markers of inflammation, or is it right down to barrier integrity and complete normalization of the epithelial barrier? And if it's the latter, we don't really have the tools in routine practice to even measure this. I mean, a handful of centers use things like confocal endoscopy, but there really are no good tools for measuring barrier function. So I think whatever it is that we measure has to be things that everybody can measure in routine practice, which I think is why histology is practical in that sense.
So I have a few questions here to let me finish. خليني أفضفض شوي. Professor Mahmoud, excellent work. We are very proud of you and the team. Excellent work. A few questions about the guidelines. IL-23, if I prescribe it as a first line, am I allowed? And I would say the Saudi guidelines said, because still there is failure of biologics, anti-TNF, and then you go for it.
Okay, so that's a very important question, and let me clarify. So these are the clinical guidelines. You might find a different perspective when you review the soon-to-be updated Ministry of Health, formulary and inter-ministry prescription guide. But it's going to be largely based on the guidelines, and we worked hand in hand to get this put, and so that they're in alignment. But as it stands, the recommendation is that IL-23 can be used as a first-line therapy.
Okay, certolizumab and golimumab. Golimumab in UC and certolizumab in Crohn's. I don't see a lot of practice done. And what about this sphingosine, this ozanimod and even filgotinib are not used practically? Why is that?
Yeah, so you're absolutely right. It's not available. So, as you know, filgotinib is not available in the country. Ozanimod is at this point not approved by the Saudi FDA. And it's not present in the market. Certolizumab Pigol is available, but it's not commonly prescribed. And finally, golimumab is available. It's largely golimumab and certolizumab is largely prescribed by rheumatologists. You'll find in the GI community we don't really use it that often.
Even in North America? Are you using golimumab and certolizumab?
No. No, absolutely not. I mean, golimumab is obviously having a bit of... So actually, golimumab is actually an underrated, underutilized drug. I mean, it's first subcutaneous anti-TNF. We've now had a resurgence in use of subcutaneous anti-TNF because we've got sub-Q infliximab, and you get these beautiful steady trough levels. But I have a number of patients on golimumab, and they've done completely fine. Obviously, it's having a resurgence now.
It's good in UC.
Yeah, and I think it's having a resurgence now because of the combination trials of Duet, where it's been combined with IL-23. So I think if those trials are positive, we're going to have a new co-formulation with golimumab. So I think it was never really utilized, even though I think it's a good treatment.
And ozanimod and etrasimod?
Yeah, I think ozanimod had a slow uptake, but etrasimod has had a good uptake. Has really been really positioned more as a first-line agent. People have failed 5-ASA. And I think overall, there's some very basic things that you have to do before in terms of EKG and eye checks in high-risk people, but I think they're excellent first-line agents, people used to taking oral therapies.
Excellent.
Dr. Habad, can we ask one question from the floor, if anything, and one by you?
Yeah.
Okay. Any question? If there is no question, it's okay. You can carry on.
Here.
تفضل.
Okay, Majid Sahafi. Congratulations, Prof. Mosley and colleagues, for this very important guideline document. You put a nice table comparing the key differences between the Saudi guidelines and the international guidelines. So what we noticed that many of the recommendations were given or classified as strong in the Saudi guideline, while they were classified as conditional or less directive statement. So is this based on a different analysis of the available data or newly developed data?
Probably both, in addition to the position made by the expert panel involved in generating the recommendations. And as I presented, it's based on the GRADE methodology, which incorporates both the literature and the expert opinion. But I think we are at an advantage because we are about a year updated from the most recently updated guidelines. So as you have mentioned, updated literature is probably incorporated into our decision making.
Mahmoud, when we are going to see it published? Mahmoud?
It's currently in press in the Saudi Journal of Gastroenterology. Hopefully within the next 2 or 3 months, it will be released. Yes.
Great.
I have still 3 questions. First for Professor Gerard. Where do you see the artificial intelligence? In radiology and pathology, they are ahead of us, and in endoscopy, they are ahead, right? What do you think about other things? Where do you see ourselves?
Yeah, I mean, I think pathology is the easy one. Pathology images are static images, they're not mobile. When they train these things, you basically train it on the cell types, and then they can recognize cell types. I think we know from IBD pathology, particularly ulcerative colitis, that neutrophils are the most important thing. So I really envisage that, really this will largely not replace pathologists, but facilitate the work of pathologists quickly. We should be able to get something like a Nancy score through an AI read very easily, and I think we'll see these tools soon, and then pathologists have to check them out. I think for endoscopy, it'll always be assisted reading. I don't think it will replace the human score, but I think it will be assisted reading to speed up reading, essentially. And radiology is complicated, I think, but I think simple things like bowel wall thickness, which is probably the only thing that, if you're going to pick one thing that matters on MR or ultrasound, is bowel wall thickness, and I think it can assist with that as well.
Excellent. You have your fellow left, the surgeon, so you are going to answer all the surgical questions. It's very interesting about the 5 types of where is the fistula, the high fistula, the complex, and the surgery differs according to the type of fistula. And he was saying about this lift and fibrin plug and fibrin glue and this mesenchymal cell transfusion and injection. Where are we? So this is a surgical part or a gastroenterology?
I think they would like answer this question better, when, where, when to do which, you mean? Is that your question? Like which procedure to do when?
Yes, I mean, according to the site of the fistula, right?
Yeah, and how complex is the fistula?
So this is my question. When do you decide to give mesenchymal injection, which is something looks fancy?
From a medical side, when the patient failed medical therapy and you refer them to the surgeon and they can't, they put the seat on, nothing to do, and then they have to decide they're going to do for surgery or other, but then we think of mesenchymal therapy. But when to do fistulectomy or lift, I think that's a surgeon better to answer when to
I
do
thought
this.
temporary stoma is a good suggestion. Why not to do temporary stoma? It is complex perianal disease. It usually heals. What do you think, Professor?
Well, I mean, a couple of things. I think mesenchymal stem cells are typically used in very refractory cases. So people who fail.
Using it?
No, because it's not approved or licensed. So remember, there were 2 clinical trials, one in Europe, one in North America. The European trial was positive and the North American trial was negative. So it's only approved for use in Europe. And actually, it's a very complicated procedure to harvest, to have the expertise to do it. So we're not using it, and it's really used for refractory cells. I think temporary stomas also are used for very medically refractory cases, people with weeping perineums, things that haven't worked. I think the important thing is once you've been dysfunctioned with a temporary colostomy, the chance of reanastomosis is less than 20%. So once you've defunctioned a patient, remember you have to do surgical care, medical therapy. Usually when you reanastomose them, 80% of those patients get recurrence. So by the time you get to that point, it's a slippery slope. The patient's likely going to end up with a proctectomy. But clearly when you've got bad sepsis, you need to get control. A temporary colostomy is what's needed.
We have a question on the floor. Last question, please.
I just want to add a point that the issue with mesenchymal stem cells, so apart from the mesenchymal cell transplant that was, I mean, we're all excited about the initial trials and such, but in practice, from what I understand, is that what is being done among surgeons is a very different way of injecting fat. So they take fat from other parts of the body and then they inject it, and they're considering it as a mesenchymal stem cell, which is not the case. So that's because maybe that's what you're hearing about in,
there is the adipose tissue.
Yeah, that's
and
completely.
the mesenchymal.
Yeah, that's not the same thing. So the trials in IBD and Crohn's was for mesenchymal stem cell, and it was, I mean, it's largely underwhelming what happened with that because it went nowhere.
I think one of the really important messages from those studies is have a very low threshold to have an IBD or colorectal focused surgeon see the patient, because simply curetaging, cleaning out the tract, a fistulotomy, ceton assessment, those things are really, really important. And I think we don't refer the patients early enough, or you might not have a surgical collaborator that has a low threshold to see those people, but basic good surgical care results in really good outcomes in those patients.
How long you keep the ceton usually?
Depends on how complex
Is
the
that your
fistula is.
decision or the surgeon?
No, I think you have to make it jointly. We've got to decide what the goal is for the patient, right? If they've come with a simple fistula tract, first perianal abscess, it's been drained, they've had antibiotics, they've got medical therapy, you've got a ceton in, you've got control, no further abscesses, you want to take that ceton out within a few months to allow closure of the tract, or the tract will never epithelialize. Conversely, if you've got a patient with multiple fistula tracts, always coming in and out, sometimes we keep those cetons in almost indefinitely or until they fall out because they keep getting recurrent abscesses. It depends where the patient is on the journey, what the goal is.
Yeah, last question, please.
Yes, I would like to kindly ask the speakers of your experience since you came across the preparation of the guidelines about something away from inflammatory bowel disease, which is the use of biologics in the treatment of microscopic colitis. I understand that both of you came from Western Ontario, where earlier studies, the Cochrane analysis has been done by Neil Chandy before, many years back, and I believe there are lots of literature coming from Western about that. If you can give me some insights.
Yeah, so microscopic colitis is somewhat rare in the kingdom. I mean, most of us see 1 or 2 cases a year. And unfortunately, even worldwide, globally, it's still considered a rare condition. So the studies are very infrequent. I mean, the literature is sparse, and I think there's no real clinical trials done in that regard to really tell us what is the ideal treatment. So I think most of the treatments available are based on anecdotal data and case series and very small studies. Don't you think?
Yeah, I think that's right. I mean, we do have a pretty large cohort in our centre on vedolizumab, but these are people who are truly steroid dependent. Remember, the response to steroids is so high, but there is a group of patients who are steroid dependent. And again, we've got observational data on vedo, quite a large number. There are some studies starting now in microscopic colitis. There's an investigator-initiated study in Europe of etrasimod for microscopic colitis, and I think there's some renewed interest in this area as people are trying to repurpose drugs for other conditions. But I think to Mahmood's point, most of these people do well, but there's generally a refractory group of patients where something gut-specific may be of interest. But yeah, we do use it, but I think they have to be steroid dependent.
Yeah, I would like to thank all the co-chair, and all the presenters. I'm sorry to stop it because we have to come back in like 25 minutes back. We have a break for coffee break and for prayer time. So we'll be back 12:45. Thank you, everybody. Thank you, Mahmoud. Thank you, Muhammad. Thank you, Bashar. Thank you, Vipul. Thank you, Dr. Hamad and Dr. Fatma. Thank you, everybody.
I'm happy to introduce Dr. Dima Al-Askari. She is a GI consultant and IBD specialist. Just recently joined our Eastern region. She just came from Canada, so we are happy to have her again, and we are proud of her. So, Dr. Dima Al-Askar, the floor is yours.
Assalamu alaikum. Thank you for the introduction. It's a pleasure to be here, and I'd like to thank the organizing committee for inviting me. So today we're presenting a case of acute severe UC. So I'm going to start off with some background history. So this is a 22-year-old lady with a background history of autoimmune hepatitis with PSC overlap. She had underwent liver transplant in June 2021. She later on developed ulcerative colitis, pancolitis, in July 2023. Patient is currently maintained on combination therapy with azathioprine and infliximab, 10 milligrams per kg every 8 weeks. She'd started the infliximab in April of this year after she presented with a first episode of acute severe UC. At that time, she was maintained on vedolizumab. So she's currently failed mesalamine and vedolizumab. She's also on other immunosuppressants in light of her post-transplant status. So she's maintained on tacrolimus, 2 milligrams BID, and mycophenolate, 500 milligrams BID. So shortly after she had completed the induction doses of infliximab, she presented to hospital with bloody diarrhea, about 6 to 8 bowel movements a day. At time of presentation, she was febrile with temperature of 38 degrees Celsius. She was also a bit tachycardic with a heart rate of 106. Blood pressure was stable. Her baseline blood works revealed elevated CRP of 154 milligrams per liter. She was also anemic with hemoglobin of 8.4 grams per deciliter. Her alkaline phosphatase was slightly elevated from her baseline with 204. Remaining liver enzymes were within normal limits. Her albumin was 30 grams per liter. So patient was admitted as a case of acute severe UC to hospital. A stool analysis was done. Stool culture, C. diff, and stool for ova and parasite were all negative. And in light of the diagnosis of acute severe UC, patient had underwent a sigmoidoscopy. Apologies for the quality of the picture. I don't think it's very clear, but you can appreciate there's the absence of vascular pattern and some mucosal bleeding here and there. So she was labeled as Mayo 2 with a UC endoscopy index of severity of 4. Biopsies were obtained and pathology was reviewed, confirming active chronic colitis. Immunostaining for CMV was negative. So at this time, the patient was started on methylprednisone, and our colleagues from hepatology and transplant were consulted. They had recommended holding her MMF and cotrimoxazole. Our colleagues from surgery were also consulted and were on board, following the patient regularly. So at this stage, I'd like to turn to our panelists and get their thoughts on what would the plan be if patient would fail the steroids.
So,
well, I mean, this is a pretty complex patient with the background of liver transplantation, really triple immunosuppression with tacrolimus, mycophenolate mofetil, and azathioprine, which is pretty unusual to have all three even in liver transplantation. And her history is, I guess the details are lacking a bit, but she has pancolitis. Now she's coming in with what seems to be an acute severe ulcerative colitis with mostly rectosigmoid involvement, the rest of the colon.
It was just a sigmoid.
So we kind of don't know what her status was before she flared up. Was she like in complete, remission, endoscopic healing throughout, and this is a new flare, or was she less than responsive? I mean, those kind of impact the way how to sort of move forward in this patient. It's pretty complicated, and there are so many different things that come into play.
So a patient was like 3 months ago, had acute severe UC as well, but she was on vedolizumab. So then she was started on the infliximab. Clinically, she was doing well, CRP, like her biomarkers were well, but she hadn't had a colonoscopy yet. She just completed her induction doses of infliximab, like a week or two before this presentation.
All right, okay. All right, well, I mean, that sort of basically you have a patient who's received induction infliximab, had clinical response. We don't know about endoscopic response. Not sure what her calprotectin CRP were at the time, and now she's coming in with really very high CRP and a significant colitis. I mean, I think at this point you just have to give the steroids some time, hope that they will work. Probably they won't, but we'll just have to wait and see in the first 1 or 2 days what would be the option. Now, the question is, should we redose her with infliximab? When was her last dose?
Her last dose was about 3 weeks before presentation.
Yeah, so I mean, that's also, if you can exclude an infection, there's no evidence of invasive CMV. And I think we talked about that earlier, but it's mostly really histologic evidence of CMV. I don't really give much weight to PCR on tissue CMV, and of course, excluding other infections, then that would be a consideration as well. I don't know if any of the other members have the panel.
So just agree, it's really a complex case. The major question here, once we rolled out infection and CMV, is the duration that the patient already taken infliximab, and does it work? Does the patient respond and then lost response or not? Clearly, the patient just finished the induction, according to you. So it's really important to look at the clinical response and inflammatory marker after starting during the induction period. And as you said, the last dose was 3 weeks prior to that. During this duration of induction, did the patient clinically respond? Did the inflammatory marker, especially the CRB, which is going to come quicker in terms of the response. So if there was a clinical improvement or response and there is a decline in inflammatory marker, I'm probably cleaning after inclined toward after steroid reinduction of infliximab. In other hand, if the patient after the 3 doses of induction, which was high dose of induction, did not respond clinically and there is no improvement in the inflammatory marker, I'm leaning toward to the primary non-responder, and probably I'm not going to wait, and I will choose a different, definitely in this situation will be probably cyclosporine. It's going to hit 2 issues, which is the induction of treatment of UC, and at the same time will replace the tacrolimus in case of liver transplant. The issue with probably the best evidence right now after the infliximab or compared to the infliximab is the cyclosporine. But it comes with a lot of baggage in terms of the side effect. But in this patient, the patient is post-liver transplant. He probably gonna need calcineurin inhibitor. Yes, tacrolimus is probably less likely to have side effect compared to the cyclosporine, but in this situation, cyclosporine will be hitting both. And again, cyclosporine, we are always worried about the cyclosporine in the past because we don't have exit strategy in terms of what's the maintenance. Nowadays, we have multiple choice that we can start with the cyclosporine as induction, and then later on we'll deal with the logistic and the maintenance therapy with other alternative. I think probably we're going to discuss more later on. But there is so many things to say about the other alternative. But probably if somebody from our colleague that have something.
Yeah, certainly, I totally agree with all said. But a couple of things I want to point in ruling out infection. Probability testing of infection is very important. So knowing what is patient on and what is the risk of her infection. Certainly, her colonoscopy does not show CMV, but in these patients, we should consider CMV. CMV is not a rare, especially in our population. In Middle East is around 80 to 90% we have already exposed to CMV. Having a patient on immunomodulator like Imuran increases the risk. So yeah, certainly CMV is important. And the way we exclude CMV, and I really like to point out how to rule out CMV in patients with ulcerative colitis. Single biopsy is not enough for CMV. The required 10 biopsies to rule out CMV, because CMV you cannot rule it out from blood unless the patient has viremia. So it needs to be diagnosed by histopathology. Certainly in this patient is less possible because we don't see the typical ulcers in these patients. The other thing, her prior medication, she is on Celsep. So we know Celsep can induce colitis, so it's very important to also consider what is her prior history of the medication. Others, ruling out ova and parasite, it requires three samples. So single sample is not enough because they examine the ova parasite manually. So your probability is way much higher when you have 3 samples. So everyone should get 3 samples at least. Also seeing the level of severity indicate the response of medication. So we can see here it's Mayo2. Whenever I see Mayo2, probably she will hopefully respond to methylpred. But whenever I see deep ulcers, multiples, I know probably they will not respond to methylpred and think directly about option B, even not waiting 3 days until we have the response when we see very deep ulcers. So certainly other options are all available, but I should consider side effect as Celsep.
Sorry, just a quick comment, but probably. The symptoms is really not going with what we see in the endoscopy with Mayo2, and the presentation is not. So I agree that the patient probably will, if its pathological causes was ruled out, I think the patient will respond to the steroid. But the other thing, I think the patient also needs GI pathological panel. Immunosuppressed patients, sometimes we have to think out of the box as a general patient that we need to rule out C. diff and stool culture and ovoparasite, but those immunosuppressed patients, sometimes we have to look for other opportunistic infection in multiple immunosuppressive agent.
If I may, a comment or two. First, I'd like to thank the organizing committee for inviting me. It's a pleasure to be part of the discussion. Depending on the institution you're at, the consultation might go to general surgery or colorectal. Regardless, I think it's appropriate and necessary for the surgical team to evaluate the patient at that time. It establishes a rapport between the surgeon and the patient. It allows for a conversation about a possible surgery. It allows the patient to think about the options, to think about the questions that they need answered, and that can be addressed at a second visit, for example, a second encounter, let's say, during the same admission. The other aspects, as it pertains to preparation for surgery, especially that she's young, whether she's married or not, whether there's family planning or not, it would be a disaster to take a decision on behalf of the patient once she has deteriorated, if she can't provide that information at that time. The third comment would be is that I think it would be appropriate to consult the enterostomal therapist for stoma marking. An emergency stoma we know has poor outcomes compared to an electively made stoma. This would still be an emergency stoma, but at least the patient would get some education. The marking on the abdomen would be more appropriate. It would have definitely better outcomes. If it's not needed, then there's no harm done. But if it is needed at the middle of the night, then it's definitely valuable.
I think just one more point, management of care. I think the dose of steroids is a bit on the low end,
Yes.
and the patient should also receive anticoagulation, I think, as part of the treatment. So
Sorry, what was
anticoagulation as part of the
Oh,
treatment.
yes, she was on anticoagulation. Okay. So the thought process at the time was kind of similar to what was mentioned. So if patient had failed the steroids, the thought was that we would start her on cyclosporin, and then later on consider maintenance options. Fortunately, the patient actually responded remarkably to the steroids. So on day 3 of follow-up, her CRP dropped to 12, and her bowel movements were now 3 to 4, and there were no blood in her bowel movements. They were still a bit loose, but she responded remarkably. So I'd like to get your thoughts on whether to continue maintenance on the infliximab or re-induce at this point.
I mean, I have to say this is a pretty unusual response.
Yeah.
My guess is that there's an infectious element that was involved. I mean, Shigella, something like that. It may not have been cultured or isolated. The drop of CRP from 150 to 12 with 40 milligrams of steroids is just pretty unheard of, I think. So, but I think we'll take the good news. I think that's good news. I have to say that the cyclosporin option that Fahd mentioned is generally a good option, but I really doubt that cyclosporin on somebody on tacrolimus will make a difference, really. Because generally speaking, the data on oral tacrolimus and IV cyclosporin are kind of similar in a way. Now, it could be that her dose of tacrolimus was not high enough and so on. One can make an argument, but I think that consideration makes it, I think, less likely that cyclosporin will be an option. But having said that, I think the response is phenomenal, although certainly not one that we see in acute severe ulcerative colitis with that much inflammation. And I think, you know, one can basically continue the steroids and basically try to see if there's a, you know, a time to give another dose of infliximab, possibly for this patient to sort of build up.
I have a question. So what was the dose of infliximab?
10 per kilo.
She was on 10 milligrams per kg.
Per kg.
Yes, and planned to be maintained on every 8 weeks.
Every 8 weeks?
Yes.
Okay, so and just one comment about the tacrolimus. So I think to maintain remission, they require higher level than in post-transplants. I'm not quite, usually...
So her TAC level was 4.9 at admission.
Okay. So I think usually they need more than 10, I think 10 to 15. From ulcerative colitis perspective.
Yeah, definitely agree. There's some data suggested that the people with higher trough level, around 10 to 15, they did better with lower trough level. And as Dr. Ala just mentioned earlier, it depends on the dose. And the issue when we deal with a patient who's coming in more critical condition, we're probably gonna go with the best evidence that we have, and the best evidence probably supporting cyclosporin, which is, I'm not sure if we in ulcerative colitis we'll do trough level, but probably we do higher dose than even the transplant people with the induction dose up to 4 grams per kg. But let's say that you wouldn't give cyclosporin, and you're going to keep the patient on tacrolimus. What would be the option for the second?
Well, I think, I mean, assuming this patient, let's say, didn't respond to steroids and the options, I mean, JAK inhibition is also a possibility in such a patient. This is, again, such a complex patient with multiple issues at hand, heavily immunosuppressed patient. I would be very reluctant to move forward with these kind of decisions unless I'm really forced to. And there is some disconnect in the presentation, the severity, the CRP, the disease distribution being localized to the rectosigmoid. There's a little bit of a disconnect, but I think that may be because of this complexity in her case and all the drugs that she's on, and maybe infection, I don't know. But
yeah, I totally agree. I wouldn't, cause personally, I don't have much experience with cyclo. I think most of the hospital and IBDologists don't have much patients on cyclo because we have other options. One of the tricks I use, I ask patients how they respond directly after infliximab. The optimal scenario that we have TDM, point of care TDM, but this is not available in most hospitals, if not all the hospitals. So if we don't have TDMs on point of care, so I ask the patient, how do you do directly after your infliximab infusion? If they said they do well, so I consider escalation even an extra dose of infliximab. Some of them I may consider reinduction of infliximab. If they said, no, I feel I have some allergic reaction, I have some nausea, I saw that they require pre-medication a lot, like hydrocortisone or diphenhydramine. So probably they will have already developed antibodies, and this is where I should consider other alternatives. I think personally, again, I don't have much experience. Even our center, we don't have much experience on cyclo. I think there is a handful of patients who require cyclo. Yeah, personally, I'd be hesitant to start cyclo, especially she's on a lot of immunosuppressant medication.
Okay.
Just another comment probably about the CMV, and Dr. Shwai'ar mentioned that you need multiple biopsy. I think very important to know that when we take the biopsy, we should take it from the base of the ulcer. As we all know that the CMV is usually in subepithelium. So although it's really dangerous and tricky to take from the base in somebody with severe inflammation, but really it's important to take it from the base of the ulcer to completely rule out. And I guess it's very tricky. I think the case basically there's a disconnect, I agree with you. And probably that's why I mentioned GI pathology panel as an opportunistic infection could happen here, which I'm not sure it's, the patient, when they start the steroid, did they stop the tacrolimus?
No, they stopped the MMF, but the tacrolimus was eventually stopped for like 2 days after.
Yeah, I'm not sure if the MMF play roles here.
I mean, it causes diarrhea, but doesn't cause anything else, really.
There are some cases of MMF-induced colitis, but they can differentiate by pathology
she's
usually.
been on it for quite some time, so I
she's
doubt
been on
that
it
she
for
will
3
come
years.
in like
Yes,
this.
exactly. So patient was discharged on a tapering course of prednisone and continues to receive infliximab. She had received a dose of 10 milligrams per kg about 2 weeks after discharge and is still planned for every 8 weeks. She was last seen in the hepatology transplant clinic and continues to have 3 to 4 bowel movements a day. They're semi-solid now, and there's no blood in her stools. Her CRP is still within the same range. So thank you.
I have a comment for the, as you know, this patient is responding very well to steroids, and now she's doing well in infliximab. But in case if she's not responding to steroids, so what would be the option? As I said, one of the options is cyclosporin, and usually we use it as a bridge therapy to other biologic agents. As you know, there are small retrospective studies showed that it's bridging patient from cyclosporin to vedolizumab or stiquinumab, they are doing well. And the other option, but I don't think it's a good option for this patient because she is on tacro, is using tofacitinib as a rescue therapy. But this will add more toxicity and immunosuppressive therapy to this patient. So it might not be a good option. But just to know that tofacitinib now can be used with IV steroid, and as per TACO's trial showed that it's improved the responsiveness and the outcome.
Dr. Adima, just a question here. This patient failed vedolizumab, right?
Yes.
And there is no perianal disease.
No.
And you are giving her 10 milligram per kg infliximab, in spite that she is on 3 immunosuppressive. Why you gave her 10 at that time? 5 was not enough, you think?
Okay, so thank you for the question. So the patient, when she failed the vedolizumab, she had presented with acute severe UC.
Okay.
So that's why the accelerated dose at the time.
So after you give the steroids, do you try to reduce the duration instead of 8 weeks to 4 weeks, or do you think it's okay?
She's still on the standard tapering of prednisone.
Sorry?
Yeah, I can comment. So this is a good question. So yeah, usually it's a case by case and a clinical, decision. As per recent studies, there is no difference, between accelerated dose or intensified dose for induction. Okay, but again, case by case, this is a very complex case, and theoretically speaking, those patients with acute severe UC, they might have more gut permeability, so they lose more infliximab, okay, through the membrane, and they have more fecal loss. So you may, give them higher dose to reach the level, to get the level high, okay? But as per evidence, you have to, apply this rule to selected patients, especially those patients with low albumin and high CRP. So those may benefit from high dose.
So, Dr. Hamad, your question is what they're going to do next, and Dima was telling that the patient is in tapering. I think now they have so much time to do TDM, and based on the drug level and antibody presence, I think the next step will be obvious. Earlier, we were talking about the time we wouldn't have the luxury to do TDM in acute setting for deciding giving infliximab in this admission. But since the patient is responding to infliximab right now, I think we have time to plan for maintenance therapy.
Dima, I have a question for you. I think this case is pretty intriguing in many ways, but the question really is always to sort of, think about what's happening with the patient. So what mechanistically do you think was happening? Let's say, so she had acute severe ulcerative colitis on vedolizumab, was given high-dose infliximab and azathioprine, which I certainly wouldn't use in a transplant patient, but nevertheless. And then she was doing well, and then suddenly CRP 150, and then she's better after 2 days of steroids. Mechanistically, how can you explain this happening? I mean, it's either as Pat mentioned, a primary non-response, which isn't the case because she was responding, or, suddenly something over and above what happened, which is, that's why I personally think there's something more to just an acute severe ulcerative colitis in this patient. But again, this is my guess because I have little information.
Okay, so I really can't explain exactly why this happened. That's the thing. But yeah, you're right. So when she did present initially, the thought was that there might be an overlying kind of sepsis, but then nothing was detected, and she did respond beautifully to the steroids, which makes it less.
Was she given antibiotics at the same time? I assume she did. They always kind of do that. Was she given antibiotics just empirically initially?
No.
Wasn't? Okay.
So I guess what go against the infection cause is that the patient respond to steroid without giving any antibiotic or any...
I don't know if she got antibiotics or not. It kind of strikes me as somebody that sick, that immunosuppressed, coming like this. Yeah. And not being covered for community acquired initially until the cultures come out would be strikingly unusual. But anyways, I'm just guessing.
Okay.
I mean, the patient basically did not have any systemic symptoms like fever, leukocytosis.
She had the low-grade fever, but then it was thought with acute severe UC, it wasn't consistent. It was just the one reading.
But I definitely agree with Ala. If the patient presents with acute severe UC in the presence of systemic symptoms, fever, leukocytosis, the patient should be covered with antibiotic until you get the result. If in some time the culture, stool culture, wouldn't catch up with every bug there.
Maybe I want to ask the audience, has anyone seen an acute severe ulcerative colitis with a CRP of 150 that goes down to 12 after 2 days with 2 days of steroids? I mean, that's like incredible.
Too quick.
In a way. I mean, you don't get that with infliximab or with tofacitinib or with anything for that matter.
I have comments. So for this complex case, any preference, let's say that I know you start in vedolizumab. Let's say that she is biologic naive. So any preference we choose?
As in the initial?
Yeah.
So the vedolizumab was chosen because she was on a lot of immunosuppressants. Yeah. So that was thought to be kind of the safest choice. Unfortunately, she didn't respond.
Yeah, it's a good option, but if you look at the case series, there are multiple small case series show that all biologic agents, including anti-TNF, stickimab, vedolizumab, might be safe in this population.
It's really interesting to see the patient after the infliximab. Like you said, she came with acute severe UC, and after the induction, that's within 6 weeks,
Yes.
had another acute severe UC. In between those attacks, the patient was doing fine, or I think this is a big question here.
Yeah.
It's an unusual case. I mean, usually if you don't respond, you flare again, you lose your colon almost, when you say.
Yeah.
But anyways, I think this really highlights complexity added on top of the complexity of acute severe colitis in a patient heavily immunosuppressed and who's coming in with this. So, she's lucky in a way.
Yeah. Hopefully.
A question if we have time for the panelist, actually. She had one prior episode of acute severe. Okay. And this is the second. And both have resolved. She gets a third or a fourth, let's say within a year, let's say within 2 years. With the panel, I'm just trying to understand from a GI point of view, would you try to elect that this patient comes in for elective surgery and avoids emergency surgery, or would you re-challenge with whatever available medication?
I think this is a shared decision between the patient and the physician. But definitely, as long as the patient responding to the medical treatment, I'm probably not going to push the patient for surgical, as long as I'm able to save the colon. Otherwise,
even if it's repeated episodes, for example, within the same year?
So certainly, I think collectomab, like one of the biologic treatment, is important, and we should always consider it. Even if with the failure of infliximab, patient already failed infliximab steroid, the optimal, through guideline of the TNF, if she's continuing having active disease, we should consider colectomy. Why? 2 reasons in this patient. And for surgical intervention for patient acute severe UC, time is correlated with morbidity and mortality. Whenever we delay surgery, more complication, more adhesions, especially in this young patient. Also, again, as Dr. Faisal mentioned, the type of surgery is different because this is a young female in childbearing age, so she will end up with endoleostomy until she completes her whole pregnancy family planning. Other thing, her liver disease will improve. There is a lot of studies that total colectomy decrease the risk of progression of PSC. So certainly, surgical intervention is an option, especially if she failed 2 biologic therapy. We may consider it certainly after a failure. After actually 3 days, we should already give the patient an option of total colectomy because time is matter a lot, and delaying the surgery carry a lot of morbidity and mortality in these patients.
Just to follow that up, if she had required emergency surgery, let's say she went to ICU, she was on pressors, there's no perforation, but we felt that she has failed medical management, she's going to get a total colectomy with an endoleostomy. Whether it's laparoscopic or open, that's up for debate, especially with her previous liver transplant that's likely done open. But she would get a stoma. If she had come in an elective setting, it's a patient-based discussion on whether we'll do an ileorectal anastomosis. Ideally, I want her off of biologics so that once we construct the pouch, she's off biologics because the pouch failure rate and retention are different when she's on biologics. But that definitely is out of the question when we do surgery as an emergency.
Yeah, absolutely.
You see, usually at 3rd day, we have an X-force criterion and we applied it on those patients that we start them on rescue therapy, whatever, anti-TNF or not. But on 3rd day is very important. We calculate the ESR, the frequency of diarrhea, and based on that, we know the risk of surgery. So from the day 0, we have to put the surgery on board because as I told you, on the 3rd day, if the patient not improve, the surgery will be the good option because as Dr. Mishal said, there is a very strong correlation between the prognosis and early surgery.
And just, I want to add what Dr. Shwa referring to is in the acute setting. The patient within 7 days, after 7 days from the acute setting, if surgery was delayed after 7 days, the increased mortality, morbidity. But it doesn't matter if the patient respond and we are in another episode.
Thank you.
Thank you so much. Thank you to the panel.
Thank you, Dr. Andina.
I'm still.
Assalamu alaikum. It's my pleasure to be here. I would like to thank to organizing committee and scientific committee for giving me this opportunity to present today. It will be a short, interactive case with our panel discussion, inshallah. So we'll start with our case. Yes, we'll start with the clinical case. This is a 39-year-old Saudi male who is active smoker. This patient was diagnosed with fibrostenotic ileal Crohn's disease in 2024. Its Montreal classification A2, L1, and B2. This patient is biologic naive with no prior bowel resection and no history of perianal disease. His initial presentation was abdominal pain, repeated vomiting with weight loss, although he's passing stool freely. His labs showed high inflammatory markers, fecal cal around 1,000, and CRB of 20 milligram with hemoglobin of 11 and albumin is 31. He underwent colonoscopy, which showed severely stenosed and inflamed ileocecal valve. It was not able to traverse with adult colonoscopy. Patient underwent CT enterography, which showed significantly dilated ileal lobes. It measures around 8 centimeters with fibrostenotic stricture spanning 5 cm. It is away from ileocecal valve. It's around 6 cm away from ileocecal valve, as you can see in this picture. So what do you think in this patient, best approach for this patient for our panel? Shall we go for medical therapy or straightforward to go for surgical resection?
Does anybody want to start? I mean, this is a pretty impressive obstruction that the patient has. Significant dilatation, low albumin. This has been going on for a while. I personally think surgery is the preferred option in such a patient at this point. I mean, clearly you want to decompress, you want to, improve nutrition, and try to basically do the surgery more electively than with this severe acute obstruction.
I agree that with significant pre-stenotic dilatation, this is what does that tell me is that this is probably fibrotic stricture. It's going on for a while. The problem is if you give him a trial of medical treatment, he might improve marginally, but the thing is you cannot judge the failure or success of medication. Because a lot of this is fibrotic stricture. Biologic, unfortunately, till now, we don't have anti-fibrotic agent to work against fibrotic stricture. So when I have like a significant pre-stenotic dilatation, this is for me probably surgery till proven otherwise.
And just to clarify, it was 6 centimeters or 60 centimeters from a ileocecal valve?
The pre-stenotic dilatation is 8 cm.
From the
it is 6 cm proximal to ileocecal valve.
Yes. I think eventually the patient is going to undergo surgery. If we can switch an emergency surgery to a semi-elective or semi-urgent, I think that's of benefit. As mentioned, the patient would benefit from decompression of his gut, whether he's passing flatus or small bowel movements, and that allows me to maybe optimize his nutrition. I think his albumin was 31. He was malnourished maybe. So we want to improve the perioperative outcomes. So with maybe some TPN, at least 7 days, that would be the case. And with bowel rest and allowing the small bowel to deflate and kind of assume more normal anatomy, that may allow laparoscopic surgery. But with the CT currently, it's going to be a morbid laparotomy.
And I think, I don't know, you're going to mention, there's a French study that looked at patients presenting with obstructive symptoms and the response to biologic. And when you have bowel distension to this extent, this is predictive of failure of medical therapy. So this is a high-grade stricture, and the chance of response is a lot less to medical therapy generally.
Yeah. Okay, so this is the second question already you answered. The predictors for successful response to medical therapy. So as a general patient with stricture, when we should go for medical or surgical? What are the predictors that can help us to decide? Okay.
Yes.
So I think you're talking about a patient with obstructive type of presentation, right? General, I mean, predictive to medical therapy in this patient or in similar situation, right?
Yeah, in similar.
Okay, so so the length of the stricture, the chronicity, whether it's fibrotic or it's inflammatory, patients on treatment, naive to treatment, the, like I said, nutritional status, as well as the extent of dilatation of the bowel. Those are kind of the predictive factors that generally tell you that patients may or may not respond to medical therapy. Yeah.
Yes, also time is an important factor. So a lot of these patients who presented initially with obstruction, when you ask them, they have their symptoms dated years before the presentation. So if I have somebody who's progressing, through a long time, that tells me this is probably not inflammatory stricture. He progressed to fibrotic stricture. The other part that we didn't talk about is endoscopic treatment. So sorry, I missed this information. What's the length of the stricture? Like not the pre-stenotic dilatation, the structure.
5 cm length,
5
but
cm.
it is 6 cm from LUC.
So yeah, it's in the verge. So some of the guidelines said you might try endoscopic dilatation up to 5. It's like short, but also this can go either way around. So short strictures actually, these are the good candidates for surgery because you have a limited resection rather than resecting a large portion of the bowel. But you might consider also if the patient is reluctant to surgery or there is contraindication, endoscopic dilatation could be one of the options.
Okay, this patient was assessed by surgery and he agreed to do surgery. He underwent exploratory laparotomy with bowel resection and anastomosis. Straightforward, 4 weeks after surgery, he was initiated on adalimumab monotherapy as induction, followed by maintenance 40 milligram every 2 weeks. After that, he was doing fine. He is in a clinical remission when improving in inflammatory markers. However, as per recommendation to do colonoscopy 6 to 9 months post-operatively to assess for recurrence, the colonoscopy showed large ulcer seen in the new terminal ileum with normal intervening mucosa. Drug level was done for this patient. It was therapeutic. It is 9.1 with no anti-drug antibody.
How much they remove resection? The resection, how much?
The length of 5 cm. So now what are the risk factors that may contribute to this patient post-operative recurrence?
Yeah.
So
there are, the traditional risk factor for high risk for post-op recurrence: male, gender, smokers, multiple surgery, biologic failure. But some of these has been debunked, to be honest. And I just saw a recent study. We initially, at classical teaching, we thought that fistulizing disease is a risk factor for post-op recurrence. And that study did not correlate with post-op recurrence. So I think, these are more of expert opinion, but we don't have much of evidence to say, apart of maybe smoking and male gender, to say this is high risk or low risk. But this patient, of course, he has multiple risk factors. I personally, I would put him on prophylaxis. But yeah, I was just shocked because fistulizing disease did not shown to be a risk factor for recurrence.
I actually have a few comments regarding this because we have some from the surgical literature. So I can't remember, maybe 2018, 2019, the Kono S anastomosis came into the field. This was the Korean doctor that developed a special way of constructing the anastomosis.
Kono, yeah.
Kono S, yes.
Kono S.
The idea was and it has undergone modifications since, was that you would construct the anastomosis with excluding the mesentery from being close to the anastomosis, with having a supporting column between the two segments of the anastomosis. The initial studies were very, very promising. The follow-up studies were also promising, but maybe not to the same extent. So maybe it does not contribute, maybe it's not a risk factor for recurrence, but maybe there's something surgical that we can do to reduce the risk of recurrence. That's one. Second, whether Crohn's disease has a mesenteric element that is primary of the disease or a reactive to the disease, I think my understanding is that that's still part to be debated. Should we do wide mesenteric excisions with our resections or not? Experts in the field also, if they're not doing a cono-S anastomosis, sometimes they're opting for an end-to-side anastomosis, kind of recreating the configuration of the ileocecal valve. And they swear by this, that it reduces recurrence. So I think there are a lot of surgical factors that come into play also.
So type of anastomosis will affect if it is side-to-side, end-to-side, or cono. You preferred cono anastomosis.
So it's technically challenging. The recommendation is not to perform the anastomosis if you're not trained for it. There is a learning curve, but the literature on people who do cono-S anastomosis, initially done only open, and over the last 2-3 years, now it's done laparoscopic and robotic, that is associated with lower recurrence. I think the data needs to mature a little bit more. Maybe it's not going to be as good, but currently that's where the needle is pointing.
I have a question. This patient was put on adalimumab preemptively right after surgery, although he doesn't really fit the general criteria for a high-risk first surgery, not a smoker, but I mean still smoke. Well, even if it's a smoker, that's just one factor. I wouldn't put everybody on. I mean, the first surgery in a patient who usually has localized disease.
Because his initial presentation, like about obstruction, so he needed surgery front away. A smoker, male, that's why we discuss with the patient and agree for preemptive prophylaxis.
His endoscopic evaluation shows just that single ulcer, or there's multiple other lesions more proximal?
Yeah, there is multiple.
Yes.
So, Muhammad, one comment here for Dr. Faisal. When you decide to do resection and we map it by endoscopy, MRI, and everything, do you do safety margin in Crohn's? Do you cut, let's say, 5-10 centimeter here, or you just take that segment?
I think the landmark studies were in the 60s or 70s. I can't remember done by whom. There was an RCT that compared a 12 centimeter margin or a 15 centimeter margin compared to like a 3 centimeter. The idea was that, do you need microscopic clearance of disease? Not clearance, yesterday we used the word clearance, so I'll stay away from that. But do you need no evidence of active disease microscopically or macroscopically only? Okay. And the results are basically the same. So usually we're going to look at the creeping fat, we're going to look at where the bowel is more leathery feeling, wherever the area of stricture is, and we're going to go proximal to that 2-3 centimeters. Okay. So for a segment that was 6 centimeters from ileocecal valve, probably our small bowel resection is less than 10 centimeters, along with the ileocecal valve, and not much of the ascending colon in this case.
Okay, now this question. This
patient, maybe if you took it, maybe there will be no recurrence.
So there are studies that looked on, let's say we do an MRE, and there is a stricture that is not symptomatic, that is more proximal in the jejunum, for example. Do we need to address that or not? The data is there. A portion of those are going to become symptomatic. The time period varies, but we have different options at that time. Let's say I am doing this surgery as an emergency. That other stricture is not currently symptomatic or it's not currently problematic. I can do stricturoplasty in the future, preserving bowel length after I've optimized the bowel, optimized the nutritional status, for example. Yeah.
Okay, now the question, this patient has endoscopic recurrence who is anti-TNF exposed. So now what should we keep him on? What is the best biologic or small molecules Although we have data from a preview trial for vedolizumab, are you agree to start an or other biologics or small molecules? As Prof. Ala.
I mean, clearly he's failed mechanistically for the adalimumab. So I think you just have to sort of, I mean, your options may not have a high level of evidence for use in post-operative recurrence and TNF failures, but you could probably use any second-line drug, really.
What about vedolizumab? It's good evidence.
I mean, certainly it's an option, but I think it's a weaker option than, say, ustekinumab or the IL-23s, I would think, in this patient, or even JAKs.
I think also depend on extraintestinal manifestation, a pregnancy preference in terms of JAK inhibitors. But I think, the evidence is supporting Vedo in post-op. As one of the few medications that has been studied for post-op recurrence. So, if I don't have, if the patient did not fail it in the past and he doesn't have extraintestinal manifestation, actually, I think it's a good option.
I mean, we may be sort of using data out of context here, but generally speaking, Vedo as a second line in CD is an inferior option. Now here it's a post-op recurrence. Does the same apply? I would think yes, conceptually speaking, but I can't be sure.
Okay, excellent. So now, do we have any strategies that could prevent recurrence other than smoke cessation? Anything we can do?
I want to maybe do a provocative statement here in terms of smoking. I think smoking is a risk factor for recurrence. Smoking is a risk factor for fistulizing disease, is a risk factor for worsening disease. However, we've shown, and there's some debate to this, that once you're on a biologic, smoking doesn't really matter. I'm not saying that people should continue to smoke, but the effect of smoking becomes marginal when you're on a biologic.
Interesting.
So, which makes sense to me.
Yes.
I mean, how potent is this tobacco that overcomes even a biologic? So, I mean, obviously we tell patients to stop smoking because it's bad for them anyways. But other strategies to prevent recurrence would be tough, really. I mean, other than, the surgical aspects, I think the cono, the mesenteric resection have been done, so you can't really remodify that at this point.
Yes.
We had a very good lecture about diet and nutrition and enteral feeding, and I'm interested about I don't know whether Ala or someone else mentioned about the oral zinc in the era of corona, and it is protective for recurrence for oral zinc, one tablet. I'm just speculating.
Those Hamad are good for mild to moderate Crohn's disease.
Post-operative, I mean, just to reduce the recurrence.
Yeah, but I mean, once you get like a deep ulcer on adalimumab, I think it's a different ball game.
Curcumin, other things. I'm just saying, whatever. We had a very good lecture on enteral feeding and diet, and I don't know. But we need to think this is very forgotten, and nobody is interested in it. In diet and malnutrition and whether anta wa ma ta'kul, this is what makes everything.
I think actually there is growing interest in, at least maybe not nutrition per se, but the microbiome and how that is going to affect whether it's cancer or IBD progression or such. And there's more literature nowadays, more towards UC and fecal transplantation and how that affects resolution of the disease. I think in the future we're going to see a bigger role for the microbiome, maybe identifying specific traits or certain populations that benefit from adjusting through nutrition or through supplements.
Yeah. So I prepared a talk regarding nutrition recently, and I found some data actually supporting the removing the ultra-processed food. That the amount of ultra-processed food serving per day correlate also to post-op recurrence in some study. It wasn't standardized, it's not endoscopic data, but there might be a signal. So a general advice, so one of the most common question I get asked in the clinic, what should we eat? And I told the patient, as of now, the evidence supporting removing the ultra-processed food. So going back to what your grandfather was eating. Yeah, no more McDonald's. But also the other question asked is, what can we do to prevent post-op recurrence other than biologic agents? There were, I think, some older evidence for the antibiotic, for the metronidazole. What I do in practice sometimes in patients who I am not sure, or they don't have much of high-risk feature, till the time I scope them, I put them, temporary on, like in the immediate post-op period, or sometimes it's done even by our surgeon to put them on flagyl post-op, because there are some evidence of to decrease the post-op recurrence. Till the time you can assess the TID dose, the standard dose. Or BID maybe for the convenience for patients who cannot take TID. But there are some evidence for it. It's not as strong as the evidence for biologic, but if you want something temporary, especially if somebody's having abscesses or microabscesses or sinuses, you want to put them on antibiotic for two reasons: decreasing the inflammation, decreasing the infection. And then you can reassess them, with the scope and see if they have recurrence. But this is something, conventional therapy that you can use meanwhile till you can scope the patient to assess the need for biologic. Because my take is if you put everybody on biologic post-op, automatically you will never know who needs it and who doesn't need. There is a good portion of patients who will have a surgically induced remission, so they don't need biologic.
Absolutely.
If you put everybody on biologic, you wouldn't know who's these patients. So some patients, you need to give them the benefit of doubt. You give them the chance, you reassess them, you see if they recurrence or if they have recurrence or not.
What did you do with your patient? What did you give?
Bestcubes was recently done and drug level just now. Still, we did not decide, but we'll discuss with him different options. We'll see maybe what to give.
I'm sure you give it them for the low-risk patient. Post-operative low-risk patient, you give them antibiotic.
Yeah.
For how many weeks? Or
I keep it for a couple of months or 3 months till I can scope them.
Till 3 months.
Yeah. 2 or 3 months.
I mean, there is a randomized controlled trial that showed that you can do that, but it's really not a recommended step generally, because the side effects of high-dose tinidazole, the studies were tinidazole. I mean, you could, I guess, use metronidazole, but it's really tinidazole. The side effect profile of neurotoxicity, etc., with prolonged use is significant. And then it didn't seem to have a big impact on the 1-year recurrence. It's just a short-term 3 months recurrence risk that's reduced with a minor effect on a long-term term. So I don't know that it's worth it. I don't think people practice it at this point. Like I think, like Bashar mentioned, it's possibly an option, but I think most people don't use it. No.
There were it's like an older study prior to the biologic era. So some signals for before the people starting using biologic for azathioprine, but it wasn't that strong, to be honest. So nowadays I wouldn't use it unless somebody is like.
So for the panel, when usually you scope post-operative? What is your criteria? When do you scope? If the patient is asymptomatic, he's doing fine.
I usually do like fecal cal in about 3 months. Fecal cal is a good indicator for.
If normal.
Yeah, if normal, I might stretch them out to about 6 months. But if it's high, I might scope them earlier.
The question, he developed a deep ulcer, so we need to give the anti-TNF. We start the anti-TNF as soon as possible.
Yeah.
So what is the optimum time you think? Ala, what do you think?
Starting treatment?
I mean, to scope earlier.
I think I think a low-risk individual is, somebody who's had the first surgery, doesn't have any additional risk factors for recurrence. You can scope them at 6 months. Whether you do a calprotectin at 3 months, and if it's more than 150, do it earlier. I think you generally don't lose that much in such a short period of time. So 6 months, you can probably extend even if the calprotectin is persistently normal or low, you can go a bit longer. It's not going to be such a time deciding on this. But a high-risk patient is one that you'd want to put on treatment and do tight monitoring. So those kind of patients, you need to basically do it every 3 months in terms of follow up their CRP, their calprotectin, and maybe do another endoscopy or colonoscopy earlier.
Okay, so my take-home message, Crohn's disease frequently recurs at the anastomotic site. That's why post-operative surveillance colonoscopy has to be done. It is crucial to detect any recurrence. Biologic therapy will reduce but does not eliminate 100% the risk of recurrence. So the timely optimization or escalation of medical therapy is required to prevent further progression. And thank you for your attention.
السلام عليكم. الحمد لله تم المؤتمر على خير. As we came to the end of this conference, I would like to thank everyone, especially organizing committee, scientific committee, speakers, chairperson, participant for your great contribution and commitment. I would like also to thank our partner, the companies who for the generous support. As we come to the end, the information that has been disseminated here, actually it will help in advancing the care of our patient. I wish safe trip back home to everyone, and we are looking to see you soon. We are see you next IBD Masterclass, which will be in 11-12 September. So please save the date, and please join us on the stage for group photo. Then we'll have the launch. Thank you.